Okay, good morning, everyone. Thank you for joining us for the Medical Board of California Public Stakeholder Meeting. Pursuant to the provisions of Governor Gavin Newsom's Executive Order N29-20, dated March 17, 2020, this meeting is being conducted via WebEx. Public comments will be heard during Agenda Item 2 for individuals wishing to do so. In order to be ready for public comment, we ask that you please ensure your comments can be heard clearly by being connected to the audio of this meeting through the proper method. If you are having difficulty hearing the audio of this meeting, it could be because the device you're connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device's audio, please click the ellipsis button at the bottom of the WebEx application or the Communicate menu item at the top of the WebEx application, and then select Audio Connection. You'll see an option to call in and will be provided with a telephone number, access code, and attendee ID that you can use to connect to the meeting via audio or via phone. Using the information provided, it will automatically disconnect your device's audio and connect using your phone to the name you joined the meeting with. By using this method, if you are having audio problems with your device's audio, this will still allow you to participate and hear the audio of the board meeting. Please see the instructions on how to connect link on the last page of the meeting agenda for step-by-step WebEx instructions, including screenshots. President Lawson, you can now start the meeting.
Thank you, Sean, and thank you to all of the members of the medical board staff, to the medical board members that have joined the call, and to all of the members of the public and stakeholders that have joined this important meeting today. We really appreciate your attendance and participation. And, the purpose of this meeting is to create a new and hopefully a collaborative dialogue with all of you, our public stakeholders and those who are interested in our work. In just a moment, I'm going to offer the opportunity to the medical board members that are present on the call to just offer a few opening remarks as well. We'll want to keep those short so we can keep most of the meeting to hearing from the members of the public, but I'll offer that opportunity shortly. And then following those comments, we're going to hear first from Bridget Gramme of the Center for Public Interest Law, who has really been a leader over many years in consumer protection advocacy. And then following Bridget's presentation, we look forward to hearing directly from all of the meeting participants. It looks like we've got over 40 of you that are on the line as of now. And we're interested in hearing, your personal views that you have to share. We're also interested in hearing, if you're from an organization, about your organization's priorities. Each participant is going to have up to 5 minutes to present on, that sort of mission and values information as they pertain to the Medical Board of California's mission of consumer protection. And we really do hope to learn about how all of you represented today are, interested in our work, how we can collaborate and help each other, advance consumer protection in California. We're very interested in working collaboratively in areas that are within the jurisdiction of the Medical Board of California and on the, topics and procedures that the statute authorizes the board to change. Of course, in the past, I know there have been matters that perhaps aren't within the board can do. And I hope that today's meeting will encourage, at least preliminarily, a conversation about what we can do, what we can't do together. We're looking forward to being able to have a bit of a conversation when it gets to that public comment period, if you will, under agenda item 2. Our goal here really is engagement. I know it's awkward in this WebEx format, but we're hoping we'll be able to have a back and forth and question and answer again, so that we can determine how best to work collaboratively going forward. Just in terms of housekeeping, the meeting is scheduled to end today at 1 p.m. We hope we have time for everyone who wishes to make a comment at today's meeting. We're going to be checking in around noon since the meeting is scheduled to end at 1. We'll check in around noon to find out how many commenters are left and to make sure that we set some parameters so that we can end on time at 1. And with that, I'd like to invite the members of the board just for some brief opening remarks. So Sean, maybe you can help me go through the list and identify who from the board is on the call. And if you could just limit your comments to a few moments so we can get into that important public stakeholder input.
Yes, I see Ms. Campaverde's join us.
Hello, I'm so excited to be with everyone today. I'm one of the newer members of the board. I think I'm at about 6 months in my tenure. But you know, I am a public member, and what I think is my most relevant experience and why I'm so excited to serve on the medical board is my experience as a breast cancer survivor, as a BRCA mutation carrier, someone who has certainly experienced the healthcare from every angle. And so patient protection is very much at the center of my mission for being a part of the board. I know firsthand how vulnerable patients are when dealing with the medical system and surgical and having surgery and so on. And so I am very passionate about being a voice for the public on this board. And so these patient advocate meetings are particularly of interest to me, and I'm really excited to learn from you all how we can all work together to improve process.
Thank you, Ms. Campaverde. Next, I see Dr. Hawkins.
Did you say Hawkins?
Yes,
Yes,
Dr.
okay.
Hawkins.
Oh, great. Yeah, Randy Hawkins, Secretary, physician in private practice, Inglewood, California. I'm very pleased to be present and to see that we're moving in this direction. I'm the chair of the Public Outreach, Education, and Wellness Committee, and that committee will be reactivated, and it will not work without public input. And those are my open comments. I'm really excited to be here to get take some notes and hear what people are thinking.
Thank you, Dr. Hawkins. Next up, I see Dr. Thorpe.
Thanks, Sean. For some reason, my video doesn't seem to be working. I don't know what the issue is there, but I am also a physician member in private practice in Northern California, in Paradise, California. I also have been, I've been on the other side of the besides being a physician, I've also been a patient, being a prostate cancer survivor and having had the issues with dealing with and navigating the medical system. I am very excited also to be here and to be able to listen to what our public stakeholders have as their concerns, because I know many times on the board, our agendas are somewhat scripted, and I think this opportunity to hear from you all is really an advantage, and so I look forward to that. Thank you.
Thank you, Dr. Thorpe. Next up, we have Mr. Watkins.
Hey, good morning to my fellow board members and to the stakeholders. I'm just happy to attend this meeting and kind of get more input into a better understanding of what really the pains are in the stakeholder environment. There are many pains that I am trying to address that I have found, but mostly my reason for being here today is that I just want to ensure that when we get this feedback, that we as the board actually take it in good faith, because we hold these meetings in good faith and with the positive outlook that we're actually going to address some of this stuff. This time, I'm actually confident that that was more of a likelihood, because I have been present where we didn't act in such good faith. And I hate to say that, but I want to be honest. But I really think that this meeting will set a new tone, and I'm fully open to hearing all of our stakeholders. So I want to thank Christina and the rest of the board for the opportunity. Thanks.
Thank you, Mr. Watkins. That looks like all of the board members I see present.
Sean, thank you. And if any board members do join later on in the process, and if you could just give me a heads up and we'll let them introduce themselves as well. With that, however, I'd like to turn the meeting over to Bridget Gramme of the Center for Public Interest Law for today's opening presentation. Bridget, thank you for joining us.
Thank you so much for having me. I really appreciate that you have asked me to be here, and also just appreciate all the comments of the board members. I do hope that this is a really important step in improving the dialogue between the public, members of the public, and the board, and trying to work together, as you mentioned, collaboratively to try to get things done and for the better of everyone. So I have a brief presentation. I really want to keep my remarks as minimal as possible, because I think the most important part is for you all to hear from the public today. But I did want to just share some information based on my own experience monitoring the medical board as part of the Center for Public Interest Law. So I'm just going to share my screen here. This is a little bit about me. Okay, so I've entitled this Amplifying Public Voices and Transforming Public Comment into Meaningful Change. And really what I mean by that is based on my work at the Center for Public Interest Law at the University of San Diego School of Law, our center has been actually working and monitoring the medical board and all of California's major occupational licensing agencies for 40 years. And so we bring a lot of experience and perspective to this work. And basically what we aim to do is to hold the government accountable, hold boards accountable to make sure that they're acting in the interest of the public and not in the interest of the profession that they are regulating. So that's really our whole reason for being. And my predecessor, Julie Felmuth, was appointed by the legislature to be the board's enforcement monitor back in about 2002. And she worked really hard with the board and the inside too to understand how the discipline system works, to make some recommendations for change there. So I just mentioned that because we really bring a long history of working with the board, understanding the way it works, what it has the power to do, what it doesn't have the power to do. And so I wanted to bring that perspective to you today. So my plan for this presentation is again, I think as the board members have already emphasized, is how to improve the dialogue with the board and with the public and really gain the public's trust. I think it was apparent from those of you who attended the Sunset Review hearing and some previous hearings, the Senate Rules Committee hearing, that there seems to be a real disconnect, I think, right now between the board and the public and what's happening there. So I really applaud the board for trying to move forward and holding these meetings, just take a step in the right direction. So as far as an overview of what I'm planning on talking about, I want to first by starting with transparency, some of the limitations that the board has on transparency and some potential for reform. And then I wanted to give some tips based on things that I've learned over time in advocating before all boards, not even just the medical board, about how to maximize public comment in order to be the most effective and really create change. And then finally, I have some recommendations for the board as well as to how to build an infrastructure for better dialogue and better public trust. So this first, I wanted to start with this quote from the Dalai Lama, which I think is really powerful. It says, "A lack of transparency results in distrust and a deep sense of insecurity." And the reason that this is very true, I believe, and I think it's the source of a lot of frustration sometimes between the public and the board. But the reason that it's problematic is that the board really can only act and can only publish information that it's authorized to do by statute. And so there's really two kind of big areas that I think is important to understand. One is the statutory requirements, what the board is required to do by statute, what it has to post by statute, for example, on its website. And then there are some board administrative policies. It does have some leeway as long as it has authority from the legislature to adopt its own policies. But understanding the difference between this can be hard. And it may, I just raised this because I think at first blush, it might feel like if the board says, oh, we can't do that, it feels like they're not listening or they're not, willing to hear the public, or they don't care about giving the public all the information. But I just raise it because a lot of times it actually is something that needs to be changed with the legislature. And so I'm going to try a little bit today to explain the difference between those things and so that you can know as advocates where to focus your advocacy. Sometimes your advocacy needs to be focused on the legislature to change the law for transparency, for example. And sometimes there are things that the board can do on its own without going to the legislature. So on the legislative level, I just wanted to give you a few examples. There's the Business and Professions Code. I mean, and I am a lawyer and a law professor, so I'll try to not get too in the weeds about the law, but I think it is really important for the public to have a general understanding of how what's at play here. So the statutory disclosures, most of them, a lot of them are found in section 2027 of the Business and Professions Code. This is an area that can be amended. So this is something, if you wanted to look that up and see, you know, what does the board have to disclose about doctor discipline, for example, about how many malpractice settlements they've had. You know, there's a lot of very specific information, and all of that stuff, the things that you might see on Breeze if you're looking up your doctor's record, is really driven by statute. And so that's one example. An example of petitioning the legislature for change. This is the probation disclosure bill from a couple of years ago from Senator Hill, SB 1448. That went through the legislature. So there was a group, I think it was really mostly driven by Consumers Union Safe Patient Project. They really worked with Senator Hill, were able to get a bill through. It took some doing, but they did get a bill through that now requires doctors that are on probation for certain things to inform their patients that they're on probation. So that's an example of how you can increase transparency at the legislative level that impacts the board. I'm working on a bill right now with a patient advocate that you'll probably hear from later, Wendy Connect, called AB 1278 about, you know, conflict of interest disclosure that would require doctors to disclose to their patients if they're receiving money from drug or device companies about the treatment that they're recommending. So that's an example of some advocacy that we're doing right now at the legislature about transparency that impacts the board, but we're working with the legislature and not the board per se. And then finally, sunset review, as the board is going through right now, and many of you I know have participated in the sunset review process. This is a way for you to tell the legislature your suggestions for change, and that's what the board is doing too. They have their own requests for the legislature to make some changes in the statutes that would give them different authority to do more things. So this is the time every 4 years when the legislature looks at the board, it exercises its oversight role over what the board is doing, and then it can impose reforms on the board. At this time is a good time to do it. So this is just an example of the legislative types of reforms. And then here, these are just some examples from the board itself. So the board can kind of regulate how public comment works, you know, that they're allowed to limit the time, even though it can be frustrating sometimes, I'm sure. They also have to get their meetings finished, and so they can limit, you know, 3 minutes per public comment, that type of thing, but that's something that happens at the board level. Webcasting is something that doesn't have to be done by statute. I don't think, maybe right now because of COVID it does, but this is an example of something that we pushed the board to do at one point a long time ago and have done for other boards as well. And it really enables the public to access boards better. It doesn't necessarily require a statutory change. And then another good example of the board just acting on its own, it has its authority to do this, but didn't need a new bill to have the app that it developed. So this is another example of how the board can do certain things on its own to increase public awareness. And I'm really happy to hear, I think it was Dr. Hawkins that said that they're going to be renovating, I guess, the public outreach committee. I think that's really important. So a quick few tips on based on my experience about maximizing public comment. The first thing I just wanted to point out is that your stories really are powerful. And one thing from my perspective, of course, I am a patient, or my family members are patients, but you know, I'm just kind of working on policy and the bigger picture, but having the stories to explain in real life what actually happens and why this is a problem is just really key to reform, I think. And so I'm happy that so many of you are here today and to tell your stories, and I do want to encourage you to tell them. I think they're very important and important for the board to hear and give perspective and understanding. However, as I mentioned before, there are time limits. It just has to be that way because the board has to conduct all its business, and it just is a way to make it fair for everyone to have certain time limits. But knowing that, and sometimes these stories, especially many of you, have very emotional stories, it's important to, I would suggest, and I've learned this over time too, to kind of write out my comments in advance that I'm planning on saying, and make sure that I can say them within the 3-minute time frame. It goes so fast. And so making sure the key highlights of your story are being told in the time that you have is really an important way of maximizing your comment. Another thing I try to do, although sometimes it's not easy to know what the answer is, and I don't expect everyone to have an answer or a solution all the time, but thinking about a little bit your own story and what is it that you're asking the board to do, and how you're trying to frame it in a way that they can take action on, I think is really important. To the extent that you have the ability to do that. And I think, what's valuable about forums like this, where you have other patients that you might hear from, or even just from board meetings, I really encourage you to listen for other people that may have experienced similar things to you, and think collaboratively about how you can prevent whatever happened to you from happening to other people in the future. So thinking about what could have made a difference, what things are within the board's control that it could change that could make this experience better for the public. It's really less at this point and in this forum, it's really less about your individual case and what you want to be done in that situation. And I think you have a better chance of being heard and of things actually happening if you try to frame it in a more of a higher level policy suggestion change, if you can. And to that point, I think understanding the board limitations, like I described before, a lot of things have to be driven by statute. Sometimes you can petition for rulemaking. If it is within the board's authority to do something, you can say, I think the board can do this, and we're requesting that you start looking at regulations to impose these particular reforms that you're suggesting. I realize this sounds very lawyerish, so you may have to work with the board on it if you don't have that particular expertise, but understanding that the board is just not all powerful, that it has to only act within the authority that the legislature has given it is I think, a helpful thing to know, and maybe a thing that can minimize your frustration sometimes with the board if you understand the parameters that they're working in. And then I have some recommendations to the board as well about, these are just suggestions, but ways that the board meeting could run that can acknowledge the public comment that's heard. The way that it is set up right now, and this is just the way, and it's not just the medical board, this is how it is at all boards. You give your comment during the designated public comment time, and you just give your 3 minutes, but it's not set up that the board members can have dialogue with you. That's why I think today is really important. But it feels, I think, as a public commenter, like the board members aren't really listening. And there's not really anything built into the meeting itself to make it feel like they're listening, because maybe sometimes they can, like during discussion, acknowledge something that they've heard. But I think for the most part, based on my own observations, that doesn't happen very often. And so I think just the structure of the way meetings are set up, it kind of builds this distrust and this feeling like board members aren't listening. So these are just some ideas that I have for that. So one, and I think the board's pretty good about doing this already, but having some detailed minutes that, to the extent possible, do document a little bit better about who the public commenters are and what their general comments are. I mean, it's really not feasible for it to be a whole transcript of every commenter, but I do think the board could look at its meeting protocols and minute protocols and try to capture a little bit more in more detail what it is that the commenters were raising at the meeting. And another idea is to have a dedicated time on the agenda for board members to acknowledge what they heard in public comment if they can, or, to suggest item, like you have a dedicated agenda item always for future agenda items, right? It's nothing that you're necessarily taking action on, but it's just something that board members can ask staff to look into, or something that they would request to be heard at a future board meeting. A similar agenda item like that for the board members to say, this is what I heard today, and I'd really like to hear more about this, or something to acknowledge again, and to signal from the board members that they are listening and paying attention to the public and have a desire to do something about it. Another one is regular meetings with the public. It sounds like, based on your comments today, Ms. Lawson, which I really appreciate, that this is the first of what I hope are going to be many dialogues like this, where you are having separate meetings outside of your typical business with members of the public to understand what's happening. I think this is a huge step in the right direction. And finally, maybe at board meetings, this could be reported back, like the themes that you heard. And I think maybe you're planning on doing this already, but also a little more thought about what can we do about it? And you know, again, signaling from the board that you're trying to understand what's happening, taking these really difficult stories that all of you have to tell, and try to think about what can the board do about this issue. One of the things that I've also recommended kind of on this topic at this sunset review that the legislature do is to have an ombudsperson, an ombuds office that would be an independent person separate from the board, but an office where members of the public could go and kind of a liaison, I guess, to understand a little bit more about what the process is, what's happening if you filed a complaint, try to understand some of these details about what is and is not within the board's authority. So I do hope that that is something that the legislature is considering and that the board may recommend on its own to the legislature that it would like, because I think it could go a long way to help with some of the issues that we are hearing about at public meetings and through the legislature at their hearings. So that's really all I have. I'm happy to answer any questions, but those are my comments for now.
Bridget, thank you so much for that presentation and for joining us for this important conversation. I'd like to just ask if the board members have any specific comment or questions, excuse me, for Bridget before we move on to the to hearing from the public.
No questions, but appreciate the thoughtful presentation and would like to talk further about some of the ideas I have.
Great, thank you. I would be happy to do that.
Bridget, Alejandra, I have a quick question, just a follow up on your recommendation about a liaison's office. Do you know of another board that you think is doing it right? Another example?
No, I learned about this actually from what they do in the UK and England and Wales and their professional licensing, particularly through their legal services board. And so in work that have done separately with trying to impose or suggest reform at the bar, I learned about this model, and they do have it for other professional licensing agencies as well. And based on my research so far, it seems to have worked really well. And I know Bill Prasiska has specific experience in that. So it's something that I'm hoping that DCA will adopt in general, and something that we can bring here to improve our occupational licensing here in California.
Thank you. I also wanted to acknowledge that board member Lubiano joined following the initial remarks. And so, Lori, I wanted to just offer you an opportunity to say hello, as I did for the other board members, if you are so inclined.
Thank you, Madam President. I think this is great that we're having another opportunity to connect and especially hear from Ms. Gramme and the different suggestions that she has. And as one of the members of the Public Outreach Committee, it's near and dear to my heart to see what I can do to help and what we can do to help advance, advance where we are and improve where we are, with the public and building more of that trust and transparency. So thank you very much.
Thank you for joining us. And so I'd like to move on. Bridget, thank you again for your remarks. We really appreciate you being here and hope you'll stay with us for the remainder of the meeting as well. I do have, I guess, some formal things I want to make sure I talk about before we move into public comment. Of course, before I would ask that meeting participants please not discuss any pending complaints, pending license applications, or pending disciplinary actions that may come before the board for a decision. Those discussions are considered what are called ex parte communications, as they could provide information to the members on the call that is outside of the record, which would be a violation of the Administrative Procedure Act, and frankly would hamper our ability to impose discipline in those cases. And therefore, those discussions could create a conflict and could lead to our decisions being challenged. So again, we'd ask you please not to comment on pending disciplinary matters with specifics. I'd also ask that if you don't require the full time, please don't use it all, so that we have an opportunity to hear from as many people as possible. It looks like we have almost 60 people on the line as of now. And as I mentioned at the outset, we're going to stop around 12 just to do a check-in as to how many people we've got left in the public comment queue, so that we can make sure everyone has time to comment. And if we still have a significant number of people, we may have to shorten the overall time for each speaker. As I mentioned earlier, we do want to make this an interactive conversation to the extent that's possible in this WebEx format. So it's possible that after each speaker concludes, either I or another board member, perhaps Executive Director Persifka, may have follow-up questions, or there may be comments here. So this is one of the ways we're going to try to have this be a little bit different format from a typical board meeting. As Bridget was mentioning, there's some formality during those processes that we're really not permitted to have the back and forth that I think we would invite and would like to have here. And we also hope that, in addition to the comments you all make today, we invite you to send the board written comments, about your organizations, about, your specific individual matters, so that we have an opportunity to review those offline, review those with the other board members as well. And so please send those comments to webmaster@mbc.ca.gov. And then lastly, the recording of this event, along with any of the written comments received by May 11th, will be provided to all of the board members as well in advance of the next meeting. And I'd like to invite Executive Director Persifka to just make a few comments as well before we turn to the public comment.
Well, thank you, Madam President. I will be very brief. I want to thank Ms. Gramme for her very insightful presentation, and I would like to direct all interested parties to the extensive work that the Center for Public Interest Law has done on the Medical Council. I've read the reports going back a number of years. They're always very insightful. And if you even read the reports going back 20, 30 years, there are many of the issues identified there that we're still grappling with. And again, it's very important for the medical board to reach out to the stakeholders, and we have such a formidable stakeholder in the Center for Public Interest Law, so we really welcome them here. We're very looking forward to this. We're hoping to engage, to have a dialogue, and I would hope that the public presentation, we realize that you have many extensive points you want to make, and we'll accommodate that as much as possible. But maybe the purpose of this meeting is to try to imagine a new dialogue, a new way of us relating to each other going forward. So without wanting to restrict you, I think that's what myself and the board members would like to get out of this. How can we interact in a more productive, constructive manner? And finally, I note, Madam President, the Vice President's on the line, and maybe he would like to introduce himself.
Oh, great. Dr. Cross, it looks like has just joined us. And Dr. Cross, we had the other members of the board who are present just introduce themselves and indicate what they were hoping to get out of the meeting if you'd like to take a few moments.
You're muted.
I appreciate the time to introduce myself. I'm sorry I was late. One of the greatest frustrations of our physician board members is sometimes our patients need us. So I was with a patient, and sorry that I was detained. It's been said before, but the public reminds us, and we remind ourselves, that we're here to serve the public. And having adequate input from the public is a vital part of being sure that we do serve the public. So I'm pleased that Mr. Persifka and the board members are enthusiastic about this platform and hope that will be productive. I agree with Bill's comments regarding the Center for Public Interest Law. I have always found them to be very good positive participant, and many of their suggestions have become law and regulation and have had great influence on the board. So like others, I as well am looking forward to opportunities to better engage and work with the public. Thank you.
Thank you, Dr. Kraus. So Sean, it looks like we are ready to proceed to public comment.
Okay, anyone wishing to make a public comment today, we are going to utilize the WebEx hand raising feature. So you should see that either in the menu options at the bottom, or there could just be a button depending on the kind of device that you're in. By clicking that button, it'll raise your hand and it will queue you up in an order for me to call you in. And we will call you by name and unmute your microphone. We are going, as Ms. Lawson had said, with a 5-minute time limit. So I'll give you a audio warning at when there's 30 seconds remaining, basically asking you to conclude. And then just for the panelists, so you know, you're free to unmute and have a dialogue. As long as that's going on, obviously we'll keep the line open. But just let me know when we're ready to proceed with the next call. So first hand up I see here is from Hannah Ree. Hannah Ree, are you there? Hannah Ree, I think you might be having some microphone problems. I've gone ahead and unmuted you. I'll leave you in the queue here. We'll go to Susan Lauren. Susan, are you there?
Yes, good morning. Can you hear me?
Yes, please go ahead.
Thank you. I'm an educator activist who is exposing the harm that board-certified plastic surgeons and others do to healthy people via liposuction. I insist on changes to protect the public. Liposuction is invasive and malignant, yet surgeons and their boards fraudulently claim it's trivial, benign, and patients are safe with board-certified plastic surgeons. Angioplasty removes fat in the arteries and saves lives. In contrast, a well-known UC Denver study shows liposuction causes increase in disease-producing visceral fat in 100% of the participants. Lipo is targeted to healthy, fit people and causes an increase of insulin resistance, cardiovascular disease, metabolic syndrome, fat embolus syndrome, structural damage, metabolic and hormonal problems, chronic pain, disability, fat tissue deformity, death, and more. The medical board should not use plastic surgeons as experts for each other. Doctors who make healthy people worse or do things to kill them are not valid experts. The legal veil of board certification is used to protect surgeons who do the most harm and mislead people in the media and online worldwide to trust in the removal of healthy subcutaneous fat tissue. Medical board experts must not be allowed to testify in civil defense cases. This sets doctors like Terry Dubrow up to make money off the suffering of victims by using their medical board credentials to sway juries. This conflict of interest is harmful to victims and continues the cycle of harm. Make surgical battery a criminal, not a civil offense. Your board does not protect the public from these atrocities. Do away with the $29,900.99 under limit settlements and the gag clauses. Medical board investigations should be transparent to victims and on an even footing with the doctors. The state should appoint proficient legal counsel for victims who can't afford it, or don't allow doctors to have lawyers, because doctors get away with carnage due to the inequality of wealth, unscrupulous lawyers like Tom McAndrews, and this corrupt system that protects them. Medical records should be co-authored by doctor and patient or not used as evidence. Looking to a doctor's records is a futile way to determine guilt. For legal purpose, if it's not in the medical record, it, quote, never happened. And this is a legal veil to protect doctors. Add something like a peer-run medical harm hotline to the medical board. Medical malpractice victims are in crisis and often need immediate advocacy to stop or break the cycle of primary and continued after-harm abuse. The hotline will also be a place to report medical experiments such as injection of cadaver fat and all kinds of scams that the women tell me about. I've been in touch with hundreds and hundreds of women over this decade. Add something like, I just read that. There ought to be a limitless statute with the medical board and courts for medical harm. The embezzlement of public funds has no statute of limitations. And there's no reason a doctor who's presented to the public with medical licenses signifying they're skilled healers should violate, assault, or kill multiple people because the medical board hires experts that, as in the Hughes case, are corrupt and lie profusely, or medical board heads are biased, or the AG blew it. We need to do it till it's right, because there's nothing mitigating about the assault and slander Saulberger did to me. And until you strip him of his license, or anyone like him, for the destruction of my body and the willful cover-up, you're not protecting the public. And as long as you contract with Terry Dubrow as an expert for your board after his reprehensible perjury in my case, you're not protecting the public. And the myth of liposuction as a reasonable thing to do is perpetuated by TV shows like Dubrow's. And sadly, people all over the world watch it. People all over the world are harmed by liposuction. And that comes out of the Medical Board of California giving these guys being behind them. After one case of gross negligence, a doctor should be barred from practice. After kneeling on a man's neck for 9 hours and 29 seconds, a police officer doesn't get to do that again. After mutilating me alive for hours while I was unconscious, Saulberger should not get to do that again. Fellows who participate in the cover-up of a peer should receive the same treatment as the offender. Okay, Bridget Gramme talked about changing the laws and doing statutes. Well, I've been in touch with my legislators for 9 years now. I've been in touch with her office. I've been in touch with everyone that I can be. And I have really good, solid things to do, but I'm disabled here at home and I don't have the money or the backing to do this. And I need help in what I suggest will protect people. And I know doctors won't like it, especially plastic surgeons, because what they're doing isn't good. The last thing is let interested parties know about meetings in advance, including time limits, and the board members, please remember that we're in grieving and— Please conclude, Ms. Lauren. Okay, we're in pain and grieving, and just to be aware that if you say something like you feel our pain, that's going to put us on the defensive. If you felt our pain, things would change, trust me. This is unbelievable, the kind of pain that I'm in. And thank you for your time. I'll send in my recommendations, and I want to be part of a solution that actually works. Thank you very much.
Ms. Lauren, thank you for your comments and thank you for joining us this morning. Are there any board members that have any questions or comments or follow-up for, excuse me, for Ms. Lauren?
Dr. Hawkins, so I think it's valuable as we try to filter through some of the important things that she talked about, how we really get settle out what it is that she really wants. Some of the things are really important and are kind of obvious. And I think that Ms. Gramme's point about having folks who want to talk to focus, I'm not trying to be overly critical to Ms. Lawrence, but it's helpful. The focus actually helps. And some of us do it better than others. And I don't want to be misunderstood. I'm just saying that it's important to understand what you're telling us. And putting in writing sometimes will help if there's difficulty in me understanding how to receive it verbally.
Well, thank you. I have it in writing. I look forward to you being able to read that. And please get back to me if what I have in writing you still don't understand. But I've been submitting bullet points since 2013 to everyone I can think of. The last thing is I'm willing to give a teleconference to talk about to all the doctors. I think other doctors need to know about the harm of liposuction. Cardiologists need to know, and endocrinologists. And I had fat embolus syndrome, and I had lidocaine poisoning, and people don't hear about this from patients. And I know often it's like you want to just go to the textbooks and the other doctors to listen. But as Bridget said earlier, it's really important to hear from our stories. And I think it would be, I would just love to do a teleconference, and you can focus me by your questions. I will answer everything. I've been studying this for 10 years, and I speak, let me tell you, I speak for thousands and thousands of people who don't want to come forward. They don't want to come forward with this. It's like rape victims. They get blamed and shamed, and trust me, I do. And it's time to stop the scam. So I'm looking forward for an offer to do a teleconference where you can keep me on focus. Thank you.
Thank you. Are there other comments or questions from members? All right, maybe we can move on to the next public commenter, Sean.
Yes, next up I have David Kahn, I believe. David, are you there?
Yes, hello.
Please go ahead.
Yes, thank you. So I am Dr. David Kahn, and I am speaking on behalf of the California Society of Addiction Medicine. CSAM for short is the state chapter of the American Society of Addiction Medicine, and we represent more than 700 physicians and allied health professionals in being the voice for treatment. We put our patients first, and we always try to get evidence-based treatment out there. I appreciate the board's willingness to have this forum, and the lens that I speak from is about patient safety and doing the best for the people that we serve, people with addiction, people who are at risk for addiction, and also people who have been affected by the disease of addiction. I wanted to start by applauding the board for hearing our feedback around modifying the death certificate project into the prescription review project. I know it's been talked about at prior board meetings, but the death certificate project was a project in which death certificates were reviewed. And if there was a link between a person's death and prescriptions, that could potentially open an investigation. This project caused significant consternation amongst the providers whom I work with. And the end result is that people stop prescribing even in cases of legitimate pain, leading to people migrating to much more risky alternatives, including street drugs and fentanyl. As an addiction medicine provider, I've seen those patients who have been cut off because of fear on the part of physicians. The prescription review project, as it's been constellated, is a significant improvement. It will look at data from 2019 onwards, and it will reduce the number of physicians undergoing formal investigations, at the same time ensuring that aberrant prescribing is appropriately addressed. It will involve more robust review and multiple consultants. It's targeted to identify inappropriate prescribing and looking at overall prescribing efforts. And then physicians who are not presenting a risk will not face further discipline. Enforcement will occur after a secondary review, and I'm pleased to know that the physicians are going to be involved in this process. What I would invite is that the medical board engage with the California Society of Addiction Medicine because we carry the expertise. We understand the use of, we understand pain management. We understand the disease of addiction. But more importantly, we're physicians that work with patients and understand the realities of situations, because guidelines are useful guidelines, but the guidelines, for example, the 2016 CDC guidelines were entirely targeted towards new starts, not all patients. So I would offer CSAM's assistance in crafting this process, as well as having our members be part of the medical board review. As always, our goal remains protection of the public and the public's best health. In addition to assisting with the prescription review project, we've been pleased to be able to have meetings with the executive director, Bill Bridget. And one of the other efforts that we would like to volunteer to help with is the revision of the opioid prescribing guidelines from 2014. The guidelines were well-intentioned, but there's a lot of information that has changed since 2014. We've had a rise in non-prescription fentanyl overdose deaths, which represents the majority of overdose deaths within California. And the opioid guidelines are essentially defunct at this point and require revision. An area of particular interest that I would suggest is looking at the use of medication-assisted treatment for opioid use disorder in a low-barrier fashion. People who are using opioids, particularly illicit opioids, and people with substance use disorders lack access to treatment in large part because people who prescribe life-saving medications are fearful of doing so. For people who do have the ability to prescribe, 50% of the people do not prescribe. And of those, the vast majority only prescribe for a handful of patients. In medication-assisted treatment with the use of buprenorphine, we have an absolute life-saving treatment that medications alone account for 80% of the reduction in overdose risk.
30 seconds remain.
So with these, I would invite the medical board to interact with the California Society of Addiction Medicine and for offering our expertise to be of assistance in the ways to best help patients. Thank you so much.
Thank you, Doctor, for your comments. Are there any questions from the board members or from our executive staff? Mr. Pasifka.
Well, I'd just like to echo Dr. Khan's comments. Yeah, the executive staff have been reaching out to a number of stakeholders, and we're certainly aware that we have an extensive amount of expertise within California, and we're looking forward to tapping into that. We are in the process of setting up the task force to review the guidelines on prescribing controlled substances, and we're looking to have as extensive a consultation as possible. It will take us upwards of 18 months to put it together, but we're absolutely dedicated to tapping into the expertise that we have. We want to thank you and other groups for the interest, and we look forward to, really getting on the job. And we're aiming to have guidelines that will really be fit for purpose, will be completely up to date, and will help us. I mean, for me, the most important thing is that doctors are able to practice medicine. They're able to treat patients, and we give clear guidelines that protect patients who are in a vulnerable situation. So it's a lot of work to be done, and we look forward to working with your group and with others.
Thank you, Mr. Pasifka.
Yeah, and I would echo those comments, Bill. Thank you. Are there other comments or questions from board members? All right, I think hearing none, let's move on to the next public commenter.
Okay. And I just wanted to point out for those maybe who joined late, and I see some people lowering and re-raising their hands, and I've had a question asked. So it doesn't show you the queue on your side, but it shows you the queue on my side. So I will be calling on you in the order that you raise your hands, just so you know that if you lower your hand and re-raise it, it moves you to the end of the list. So please just trust that I'll be calling on you in the order that you raised your hands in initially. If you do lower your hand and then re-raise it again, it moves you further down the list. So I just wanted to point that out to everybody trying to get in queue. And for those of you that have maybe joined late after we discussed it, you can go ahead and use the raise hand feature in WebEx there to add your name to the list of the queue, and we'll call on you in the order that you came in. Next up, we have Eric Andrus. Eric, are you there?
Yeah, I'm here. Can you hear me?
Yes, please go ahead.
First, Bill, it's not in the mission statement to make sure doctors work. Also, it would have been nice if we had been told ahead of time how long we were going to be given to speak so we could properly prepare. I don't know how long this is, but I'm sure you'll just cut me off if I go over. It also doesn't help us to tell us what you want from us minutes before we're to speak, when many of us have spent hours ahead of time preparing our speeches. Also, why can't we just see everybody that participates? Can you please supply a list to everybody, not just the NBC staff and board? Also, this WebEx software often makes my computer crash. Just to comment on something Bridget said about NBC commenting, the place we have the most trouble is when the board says they can't do something and then quotes a law that isn't applicable, hoping we won't check, or says they won't do something like they're glad they can't, and then doesn't say, for instance, we're currently not allowed to do that, but let's work together to see about fixing that. They just shut it down. We've offered to do legwork, and the board never responds to us. In fact, I was told by Christine Lally that there is a mandate in the board office that staff and employees are not allowed to respond to me. That's not transparency. That's not communication. Even Bill Pasifka has stopped communicating with me. As you know, the medical board exists in its current state based on an assurance that was agreed upon in 1974 by the legislature with the micro law, that the board would take up the slack in disciplining doctors because when the micro law started preventing thousands of victims from hiring a lawyer to represent them in court when they had been harmed. We now know, nearly 50 years later, that the medical board never held up their end of that bargain. Now, when consumers are killed or hurt, not only can they not get a lawyer in many instances due to MICRA, the Medical Board of California then fails them by closing their very legitimate complaints and letting the doctors walk free. We also know that it was proven in January of 1993 when the Los Angeles Times exposed that the Medical Board was literally throwing complaints in the trash to clear their desks. Now that we live in the age of computer technology and digital documents, the board is clearly disposing of legitimate cases in other ways than just tossing them in a trash can. This is why we felt the need to furiously monitor every disciplinary action that comes out of this board and publicly let the state know when NBC is not doing its job properly, much to the chagrin of the board and staff. We've been doing this now for several years, and the board has regularly ignored our pleas and our evidence and has even gone so far as to break the law in order to do so. We've been chastised by board members twice now who threatened to call in the Attorney General's office in an attempt to stifle our First Amendment right to speak about our research and how the board isn't doing its job. Eric Andrus, myself, had his entire personal Facebook file subpoenaed by Kimberly Kirkmeyer at the DCA, which included private conversations with patients and victims about their cases. None of you have ever commented on that, by the way, so that just goes to show me that you all approve that she did that. So we now hope that these interested parties meetings that we can be listened to and heard instead of readily shot down at the quarterly meetings. We hope you all see that we have no intention of going away and letting the board get away with the secondary harm they create when they let people of this state down by ignoring the legitimate complaints. With our participation in these meetings, we want to make it clear that we don't want the meetings to become an avenue to divert these issues away from the quarterly meetings, thereby keeping what is said out of the official meetings, even though those minutes are often skewed and inaccurate. If we find that the interested parties meetings are just being used in a way to silence the public and or portray a false sense of caring by the board itself, we will make that known as well, as we will be documenting these meetings ourselves. There's a few ground rules that we'd like to request. 1, minutes be taken at the interested parties meetings and posted to the NBC website. 2, stakeholders are given equal opportunities to share information at the meetings and be at least equal to the presenters the board invites on their own behalf. 3, that there be a minimum number of board members present for the interested parties meetings. In the past, very few board members showed up and stayed for the whole meeting. We suggest a minimum of 50% of the board be there, always being one member and with one more public member than doctor members. In the event that there is a shortage of board members in a category, it should be specifically notated in the minutes with the reason as to why that happened. 4, stakeholders should be allowed to present information via the board's teleconferencing software, i.e. documents, etc.
30 seconds remaining.
Now see, this is what I mean. I've got 3 more things to say and you're going to cut me off. And in the event the meeting resumed in public via
Eric, just for clarity, we'll invite you to finish up your comments at this meeting.
Thank you. Via the overhead projection system. 5, in the long run, we hope the board will help work toward an official committee, not unlike the one that the CDPH has, and covers the expenses for an official stakeholder group to attend meetings. It will likely be the same stakeholders showing up for most of the meetings anyway. 6, we'd like for there to be consideration for the meetings to be held on the weekend so that stakeholders who have to work can participate. We've brought this up a number of times before, and yet here we are again with a midweek meeting. And lastly, number 7, when the board attends Legislator Day, we'd like for at least one patient safety advocate to be in attendance with the board. If board members are split up between legislators, there should be one advocate per meeting, and those costs should be covered by the board. This is important because clearly the board members are not conveying accurately the problems that consumers have with the board to the legislators. And Marian has some more to say on behalf of the Patient Safety League when she speaks. Thank you all.
Mr. Andrus, thank you for your comments. Are there comments or questions from the board members for Mr. Andrus or from the executive staff?
Lori here. If I may.
Please go ahead. Thank you.
Thank you. Thank you, Eric, for your comments and your suggestions. I think you've mentioned some great ideas there and some that we've already internally, or at least for me, that I've also brought up to staff about creating opportunities for patient advocates to introduce themselves, their mission, and meet others and network with others as well. And I also like your idea about thinking of these patient advocate meetings and and perhaps putting a minimum number of board members, if possible, to attend. So I just want to acknowledge that I hear you and thank you.
Thank you.
I've got a comment and a question as well. So first of all, you know, when Eric makes these comments, I usually make notes, and he's not wrong when he says that, you know, we do not talk to him. What happened the last year, and I want to apologize to him because this is also in to restore own professional integrity. Last year at this meeting, Ms. Labiano and myself were the only other board members outside of the board chair present at this meeting. And we acted in really good faith. Eric can attest, we had a moment where we felt we can move this relationship forward. He's by far the most outspoken patient advocate. And sometimes, you know, he gets riled up and that's okay, that's his style. We have the skills as the board to address that in an adequate manner, right? When after that meeting, when he reached out to the board, well, I see the emails and we didn't have a response. I reached out to our team to respond to Eric, and the official deal was they weren't going to respond to him. Now that is absolutely unacceptable. Unacceptable on every level. It's not the way we behave when you have a level of integrity that I think the Medical Board of California should have. I'm going to point you to some ways to achieve that. This happens to be my area of expertise. When you want to build a reputation, you got to put in place transparency. Transparency builds trust. But at the same time, you must have a commitment to actually follow through on when people ask you to follow through. On top of that, you need to have a level of empathy. When I listen to Eric, most people know he lost his sister and he's been harmed by a doctor. When I hear that passion, I also hear that pain. And it's easy to dismiss that. It's very easy to dismiss that because he can get so riled up. But when you really listen and pay attention, you really have some good ideas, as Ms. Labiano mentioned. So all that said, my question to Mr. Andres is, what would be the number one thing? And I know you've got a lot of ideas, but if I were to ask you, what would be your number one request from this board to help you help us moving forward?
Well, first of all, I'm crying. Thank you for that, TJ. I really appreciate you saying that. This is the first time I've really felt like somebody actually heard me. So thank you for that. I think from my point of view, my biggest frustration in dealing with the board now, because I've filed so many complaints and they've all been shut down, every single one of them has been shut down, is that we as consumers have no course of appeal to reopen those cases unless there's new information. We have no way to make sure that the board was doing its job in the first place. We're now finding that there are complaints that are being closed by incompetent experts. We have no way to, when I tried to do a Public Record Act request with Carrie Webb to find out who the experts were on my sister's case, to find out timelines, whether the complaint was being handled properly, they just shut down. Wouldn't give me a single bit of knowledge. The Public Record Act requires that these documents be turned over, and if anything is confidential in them, they be redacted. But all Carrie Webb does is shut it down. She blocks it completely, which is against the law. So from a consumer's point of view, we are not able to not only not monitor the board to make sure they're doing the job correctly when they close these complaints, we have no course of appeal to make it go to another level so that it can be looked into to see if indeed it was handled properly or not. My sister's dead, you guys. A doctor killed her. It was negligent. I have now suffered and been harmed. I have ongoing stomach pains after 3 failed hernia surgeries. I filed a complaint. This board retaliated against me and closed that complaint, even though the surgeon in my case wrote in my records that the surgery was done incorrectly. The medical board closed the complaint. I have no course of appeal. I have no way to make sure that you guys even know that that complaint was mishandled. We have no avenues. We have no way of getting through to the board. And when I bring this stuff up to you guys and I tell you these stories and I show you the proof, it just goes nowhere, like you said. And now that I know that they've admitted that they're not going to respond to me, that just proves that this is really bad. This is not transparency. This is not the board working for the consumers of this state and protecting us, because You're letting the doctor that harmed me and the doctor that killed my sister and the doctor that killed Marion's father and the doctor that took the arms and legs off of Annette Ramirez and the doctor that made, what's his name, paraplegic. All of those doctors are walking free because you guys, not you guys personally, but the board closed those complaints and none of the people had an avenue of appeal. So that would be my number one thing right there. Thank you.
So Eric, let me ask a specific question, and maybe you may not have an answer today. And if you don't, I'd invite you to submit it in writing in the future. But I mean, there were a couple of suggestions that the Center for Public Interest Law made in their, both in their letter to the legislature as part of the sunset review process, as well, and Bridget identified a couple of them today as well. One is this idea or concept of an ombudsman person, right? And whether that person would be truly independent, a part of DCA. I mean, I think there would be potentially a lot of details, but I hear what you're saying about the inability for a patient to appeal. And unfortunately, that's a construct of the statute, right, that we're operating under. It's not that we wouldn't all prefer that there be some type of that ability, right? It's not that we as individual board members wouldn't prefer that some type of better communication system existed, right? But that's a construct of the statute we're working under. And I know sometimes it can seem just sort of offensive when we say something like that, but we are limited in this box, right? By literally the words on the paper. So I'm just curious if you have a reaction to some of the things that the Center for Public Interest Law has proposed in that regard.
Yeah, two real quick points. First of all, yes, I know you're constrained by the laws, but what becomes frustrating is when you say you're constrained by the laws and you maybe agree that there should be differences in it, and then everybody sits back and doesn't help us go to the legislature to make those changes. You can't just say, okay, look, we're confined by this law, and then not try to do something about it, because it's not in the name of patient safety to not give people the right of appeal. We've brought this up many times, and the board doesn't do anything to help get an avenue to appeal. They just sit back and let it exist. So just sitting there doing nothing is not being a good board member. The ombudsman idea is a great idea for a start. I think there should actually be a committee, a panel that takes in and looks at appeals for situations like that. But an ombudsman would be a great start. I know the state itself has a state ombudsman that tries to intervene on things, but I'm not sure if they would get involved in specifics of the medical board like that. So yes, I think a specific medical board ombudsman would be a great start.
Thanks, Eric. Are there any other questions or comments from board members?
But just one quick thing, Madam President.
Please.
To Eric, if you haven't already, if you could submit your suggestions that you mentioned today, I'd appreciate that.
Yes, we did already submit a letter, but we've talked about some more, so I'll send in an addendum.
Yeah, and Ms. Lubiano, just for clarification, it should be in your email if you haven't had a chance to look at it, but we did receive some written correspondence from Eric.
Thank you.
Randy Hawkins, just wonder if Bridget Gramme would want to make any type of comment at all. I know she was nodding her head, and so I don't know if you don't feel compelled to, but I just wanted to offer that if possible.
Sure, thank you. I think that's a really important suggestion, Eric, about the appeal, which I think you're right, an ombudsperson could be an important step, but that is a different suggestion really than building in a review process for complaints. And that's something I'm happy to look into also and see if we can find other examples, either of other boards in California, which I'm not familiar with any that have that process, but that I think the state bar might have something like that. So anyway, maybe you and I can connect offline and think about a specific proposal on that part too.
Awesome, I'm happy to help.
I have one more question. You mentioned, Eric, that you can't monitor the board. What would monitoring the board look like in report form from your perspective? What would be in such a report? I'm just curious since we're talking.
Yeah. So this was slightly touched on at the sunset review. If the board did like the Contractor State License Board, which is your sister board, when you file a complaint with the Contractor State License Board, that complaint information goes up on their website. You can see that there's a complaint against a contractor. You can see the list of all the charges against the contractor. And when they do something on that complaint, it's dated. We have no idea when we complain about how long these complaints take with the medical board. We have no idea that you're all not just sitting there on your hands. We want to see on January 1st, this complaint was received. On February 1st, it was sent to an inspector. On March 19th, it was done to this. Or we want to see that between January and December, nothing was done on it. We want to be able to monitor that. That's transparency. We want to see what's happening on our complaints. So I think the website itself, and I know this goes back to what you can do in the law. This needs to be changed in the law so that you guys can be mandated, like the Contractor State License Board, to put this information on the website. So when we say things like that, don't think we don't know that you are constrained by laws, because we do know that, but we're trying to say that these things need to be worked on so that the transparency is open. But that would be my suggestion, is to give the public the ability to see what's happening on their complaint and follow it along as it's happening.
Thank you. Are there any other questions or comments from the board members for Mr. Andrest or from executive staff? All right, thanks, Eric, for your comments in the conversation. We appreciate it. Sean, let's move on to the next commenter.
Yes, next up we have Marion Hollingsworth. Marion, are you there?
Yes, can you hear me?
Yes, please go ahead.
Thank you. Good morning. My name is Marion Hollingsworth, and I'm a patient safety advocate. While I'm pleased that the medical board is making good on its promise to have these stakeholder meetings on a quarterly basis, I am concerned that you are not all committed to actually making changes based on what we suggest. The rules of society change when you go through the doors of a medical facility or office. In a society, if you harm someone, you are held criminally responsible. But if that harm occurs in a medical setting by a doctor, it is considered a civil case or medical board complaint most of the time. The board is often the only protection or recourse that consumers have, and more often than not, you fail us. 96.5% of the time, according to your own statistics. So I hope that changes can be made, though. First, I would like to see the board becoming more proactive in warning consumers about doctors you know are either dangerous or being investigated, as Eric Andrest commented. The reason I say this is that I have a list of 9 doctors that I know of, 9 doctors that either a family member or I have been to that have been disciplined by the board, 9 of them. I filed complaints against 2 of these doctors who had harmed my father and led to his death. The other 7 treated us before we knew there had been trouble. This includes a doctor who overdosed his own wife, a doctor with decades-long history of drug and alcohol abuse that this board was aware of, who finally got in trouble when he went after a patient with a hatchet. The list includes a doctor who treated me before I knew he was disciplined for amputating the wrong body part, not mine, fortunately, and an urgent care doctor who had a history of misdiagnosing patients, who misdiagnosed my husband. And if you add a doctor who had a $3.3 million malpractice judgment, you have number 10. The board was investigating some of these doctors at the time of our treatment. So going back to what Eric said, it's important that we at least have a heads up that an investigation is in process. If the board were more proactive about protecting patients instead of protecting doctors, I would have had more information so I could have avoided these doctors if I chose to. I know you aren't always alerted about dangerous doctors and cases until after they happen, but when you do, you should post the information as soon as you get it in order to protect consumers. Other changes I would like to have you consider are follow your own disciplinary guidelines for the majority of cases. Why have guidelines if you don't follow them? And don't allow doctors to negotiate their probations down so much that they don't have to notify patients under the Patient's Right to Know bill. You did that last year with Dr. Grant Kingsbury. He was caught in the death certificate project after overdosing a patient. He should have received a 5-year minimum year probation under the guidelines, but you allowed him to have 35 months. So now he doesn't have to notify patients. Report sexual assault complaints to the police. Don't keep these complaints confidential while the doctor is free to practice during an investigation. By reporting to the complainant to police, the case will be solved more quickly, ensuring patient safety and due process for the doctor. Involve complainants in the investigation process. Don't send investigations to different cities where complainants are less likely to be able to take part. This happened to mine. It was changed from San Diego to San Bernardino. Allow complainants to attend hearings and to take part in them. And then finally, explain to complainants why a settlement is recommended. Just don't send a copy of it saying, this is it, now go away, which is what usually happens. Consider having occasional meetings during the evening or on weekends so more consumers can attend without having to miss work. Since the board is in financial trouble, also considering fining doctors to recoup the cost of investigating and prosecuting cases. Other states like Florida and Georgia do this. Also, shorter investigation times. I know this is an ongoing thing and you're limited by your financial woes, but 3 years plus is a long time. It's unfair to both the consumers and the doctors. And finally, listen to consumers when they file a complaint about a doctor concerning egregious harm or death. Give these cases priority. If you had done that when I complained about Dr. Kingsbury, you could have saved the life of another person. We know the harm we or a loved one experience, so please believe us when we tell our stories. And one final PS, don't just tell us to change the law, because that is overwhelming to most consumers. It took us 5 years for the patient right to know bill to be passed and enacted, and twice the board voted against it. Plus, CMA donations to lawmakers make them more beholden to them and more hesitant to push laws regarding doctors. So just to say, well, you'll have to change the bill, you have to change the law.
30 seconds remaining.
Work well. So anyway, thank you for your time. Please consider my suggestions, and I welcome any comments you may have to have. Thank you.
Thanks, Marion. Are there any questions or comments from the public? Excuse me, not from the public, from board members or executive staff?
Dr. Hawkins, thank you, Ms. Hollingsworth. I just had a clarification. When you say 95.6% failure of the board, what are you referring to specifically? I'm not sure what that first.
I'm referring specifically to your disciplinary rate. Because if you look at the enforcement report that Jenna Jones gave at the last quarterly meeting, I believe it was, she said that they disciplined 3.5% of the complaints. So if you take all the complaints and just do the basic math, it's 96% of the time, nothing happens to a complaint. For consumers, that's heartbreaking. You know, and I know some of the complaints are like, well, the staff was rude to me. And so obviously that's not going to count. But for things where there are issues like a death or egregious harm, when someone has lost a body part because of a misdiagnosis or a surgical error, those should be, you know, those should be looked at more aggressively and not just tossed out. It alarmed me at the last quarterly meeting when Mr. Persifka said, you know, we don't have the money to prosecute these things. And that's a huge red flag. It makes me wonder what happens to the $62 million budget. You know, there was a breakdown on the annual report, but if so many cases are being tossed out, it's alarming and disheartening for consumers. I mean, I even had there was a falsified DNR from my dad that I found in his records, and that was not even addressed. So you know, things like that are, you know, they really dishearten us and frankly scare us.
So Marion, it's Christina, and I guess I mean, I continue to as I'm hearing the various comments, including yours, you know, thinking through, you know, where are the solutions? And I'm a lawyer by training, and so I tend to like look for all the things that are, you know, difficult, right, in a particular problem. And I think about things like, you know, it's difficult for the board ourselves. We meet 4 times a year, and we actually can't take any action on behalf of the board unless we take it all together, right? Unless we have a board meeting, we meet, we discuss a particular course of action, and then that gets advanced. And sometimes it just can be glacially slow because that's how either our process works or the legislative process works. And when I'm thinking about this, I'm thinking about, well, how can we help you change the laws, right? I heard what you just said, which is don't tell us to just go out there and change the laws because that's really difficult to do. And frankly, our process to help you as the medical board, right, as the individual board members all meeting as the board representative board itself is, I guess, unwieldy or not well suited to assisting members of the public like you change the law. We have Bridget Gramme on the line, and but I wonder if there isn't a partnership or a way for us to serve as a facilitator or a connector, right, of people who can make some of those changes or advance these objectives in a better way than we can as the board. Because I'm concerned that I just don't have the resources in the framework we operate in, right? As one of these, many boards or commissions in the state of California, I'm worried we just aren't the right vehicle for some of these things that you're requesting. And I want to figure out how we can either connect with the right organizations or figure out how we can be the most helpful. So Bridget, I don't know if you have any ideas, Marian. I just wanted to offer those comments. They may or may not be helpful, but it's just, I wanted you to be aware of where my thinking was.
Well, thank you. An example of this is that most complaints take, by your own calculations, about 3 years. And I've talked to other people in other states and they go, well, we have Washington has I think it's a 5.5 month limit for investigations. Another attorney in another state said, oh, these only take about 6 months. I go, no, they take 3 years. And I showed him some cases and he was stunned that it took that long. So, I mean, do we need a law to make it and to make that happen, to have a shorter turnaround time for complaints for both the complainant and the doctor's due process? Or what needs to happen? Do you need more money from the state? How can we fix this so we don't have dangerous doctors running around unfettered, for 3 years while you decide what to do with them? It's a huge issue. There was a hearing, in fact, one time where the attorney for the doctor said, why do you care now? You didn't care for 3 whole years. Why is he considered dangerous now? So, that is something that we need to correct. And I don't know how to do it without, legislative thing, because that's what board members have told me.
Yeah, and I mean, those are all excellent points. And frankly, I mean, some of that is exactly what the subject of some of the questions and comments were at the Sunset Review hearing, right? And as I've studied this issue as a board member, and you think about the variety of different agencies involved in, and how, I would challenge us as we go forward to think about, well, how would we design the system if we started it today, right? Because most of what we try to do as a board is figure out how to make some tweaks, right? We're kind of reacting and we're operating in a particular environment. So we're saying, okay, we're constrained already, but what if we were doing this from the beginning? What would it look like? And I mean, what would our relationship with our lawyers look like, right? Our lawyers are currently the Attorney General's office and they do very good work. But because they're basically two different departments, it's sending information back and forth rather than having it all in-house. Now, there'd be constraints to having it all in-house, right? Financial, and otherwise in the state government that we might be constrained by. But I mean, I think there is this conversation to be had. Maybe, Bridget and the Center for Public Interest Law is a good place to kind of have some of those innovative, forward-thinking conversations. I don't know that we're not always super innovative and forward-thinking in government. And I faced this, frankly, when I was in local government as well, where it was before I came to the medical board, because there's these constraints. So some of that advanced thinking coming out of a group like Center for Public Interest Law in collaboration with all of you, hearing all of your voices and pulling out these themes, which I think, again, is the purpose of this meeting. How can we start to pull out these themes and get everybody having, the right conversations with the right people?
Can audit help get to the root of the problem? Because I know the BRN had an audit, I believe earlier this year or later last year, and the medical board hasn't had one for decades, at least that I'm aware of. Can you say if there was ever an audit, and if so, when it was, and maybe that could be repeated to maybe help change some things so it was easier for the board and more equitable for the complainants?
Yeah, and so Marion, these are my comments only, because the board doesn't have a particular position as of yet on an audit. An audit under the state rubric can be constraining because they'll decide what they want to focus on versus, us taking a look at the issues we would like to take a look at. So I worry about that in a true audit process, because we won't, nor will public advocates, nor will others have influence as to the scope of that audit. So it may end up looking at issues that you didn't want to have looked at, or that aren't trying to advance some of these objectives. So that's my personal caution about that path. Do I think there are opportunities to review? And again, I have spent some time with Bridget and her group, just talking about the great work they do. And frankly, there may be other groups out there like hers that we should engage in the conversation, because frankly, I think sometimes that type of work is more productive than having the state come in, and narrow a scope of an audit and not have it be, not have it necessarily be looking at the issues we want to have looked at, or even framing the issues in the way we think they should be framed to advance the public interest. I want to make sure I get to any other board member or staff comments.
I have a comment.
BJ?
Yes, the point that Marianne raises is a lot of the stuff that I am looking into as well. And it lines up with something that Eric brought up earlier when he was talking more of like, the best way for me to describe it is like a 21st century enforcement monitoring system where, everybody, there's transparency into the system. The question that was raised about, just go help us pass the laws. Here's the bigger issue, right? The board, we as board members, we have a lot of more power as a collective body when it comes to legislation. We oppose, we are neutral, we take positions on legislative matters, right? So when the patient advocates come to us and they have a suggestion as to a law change, but most of the board members do not see that, like she mentioned that the right to know, what was that notice to the doctors that you mentioned that was opposed by the board twice, right? Now the right to know, public notice to the public, is a public protection tool. Why would the board vote against something like that, right? I've got a challenge for this board always, right? And I'm going to freak you all out, because right now we're going to go back to the legislator. I'm going to ask for cost recovery. The board has it as its sunset review. I want to really understand how many of the board members would actually support that when it comes down to it, because that's a legislative change. But first, we will always have to when the patient advocates come to us and we want to do a legislative change, then this board is the first place that you need that support in order to move that forward. Then we can go to the legislature, because we know that's going to be a different challenge. That's where, but if you have the board support, then that's a good start, in my opinion, Ms. Hollingsworth. And that 96.5% failure rate that you talk about, it honestly, when I first came across, I think I mentioned that I was just interested in that 3.5% and what happens there. And then Ms. Campoverde at the last meeting was pointing onto that 2,000 cases that was involved. And then one morning I woke up and I realized what we are missing is a real opportunity to really do enforcement at another level. Because if we had a tracking system, someone files a complaint and there's like 10,000 complaints that we get. And, you know, say about we get 20 complaints, like I think Ms. Jones mentioned that at the Sunset Review, coming from one doctor. If we're getting 20 complaints or many complaints from different doctors, then we could employ a different strategy, like Bill mentioned. He likes this non-confrontational, whatever, I don't really have the word now, way of doing enforcement. In that way, we can draft a letter like the FDA does to, you know, people that are selling illegal supplements, and just tell them, hey, we've had 10 complaints. And that would be a proactive approach. One of the things that showed up at the Sunset Review was that we are reactive. And I've been thinking, how can we become more proactive? So from Ms. to answer, you know, to help out with maybe clarifying Ms. Hollingsworth's position, is that yes, we do need a 21st century kind of monitoring system so that we actually know what happens to each of those cases. And when we want to do a legislative change, when patient advocates come to us, that we actually find the support on the board first. Because once you don't have the support on this board, it's going to be almost impossible for you to have the support at the legislature. So that's my comment. Thank you.
Thanks, TJ. One thing I did just want to clarify is that cost recovery is an official position. Restoring cost recovery is an official position of the board. It's adopted in our sunset report that went to the legislature. So that is our official position that was vetted through the board. Are there other comments or questions from board
Lori
members?
here.
Ms.
I have a
Hollingsworth,
quick comment.
please go ahead.
Thank you. Following up on what TJ was saying, and you know, this notion about changing the laws, I think that it's an opportunity for us, and well, all of us, to really coalition build. So, for example, something I think about is, you know, with the board as well as with public input, to prioritize. If we were to advocate and move for a change of law, you know, what would those top 5 or 3 items be? And then with at our position within the board, our connection to DCA, for example, perhaps to look at, you know, maybe which legislatures have more of an appetite for these public protection kind of laws, and help make the connection so we can help build, build that momentum and movement. Because we know that with changing laws, it's not an easy thing. There's strategy behind it. There's timing. There's all these considerations, and they all, you know, have to fit in place in order for it to happen. So that's what came to my mind. Thank you.
Thank you. Are there other?
Yes, it's Alejandra. I just wanted to touch on the IT piece of it, because that's also something in the communications piece that we hear you, I hear you loud and clear about the frustration of not knowing where things are in a void. And I know in the conversations I've had with staff, this is something that's actively being looked into. So I was wondering if there was anyone in the staff who could maybe touch on that for a moment.
Bill, is that something you can address?
Just to clarify, are you talking about developing a sort of a tracking system in relation to complaints?
Yes.
Okay, well, this is something which we have been working on, and that's with our ICB unit at the moment, and we would hope to give you some sort of update at the next board meeting.
Yeah, and just a clarification though, that's an internal tracking as of now, right? Because some of that information is not by law permitted to be released.
No, I mean, absolutely.
Publicly,
I mean,
it's an internal system.
Yeah, this would be an internal system. I mean, the problem that we're running up against is that the complaint process by law is a confidential process. What is published is when a complaint advances to accusation, and then that becomes a part of the public record. But if a matter does not go to accusation, it remains confidential. And the act actually provides that once a complaint is closed after 5 years, the file should be purged. And those are the that's a legal requirement.
My
Thanks, Doc.
understanding,
Yeah.
just to clarify my question, I understand the internal part of it, but versus moving away from always written communications and letters, which can be slow, the part that isn't a part of a confidential piece, if folks were able to check online to see, again, that information that was a part of the public record, an easier way of being able to understand, again, what is available information already, but through a technological solution. That was my understanding.
Yeah, well, that's what we're working towards, and that's an ongoing project.
Great.
Thanks. Any other questions from board members? Or comments? All right, Sean, I think, Marion, thank you so much for your comments. Sean, I think we're ready to move on to the next commenter.
Okay, and just so you're aware, I just saw a 12th person now enter the queue, so we have at least 12 remaining in the queue right now.
Thank you.
Grubb, are you available?
I am. Can you hear me?
Yes, please go ahead.
Wonderful. Greetings, President Lawson, Vice President Kraus, board members, staff. My name is Jason Grubb. I'm speaking with you today on behalf of CE Broker as a follow-up, actually, to the letter we previously provided last week. I've timed my comments. I won't take up anywhere near my allotted time, so I'm happy to either field questions or yield back the remainder of my time to others who'd also like to speak. As noted in our letter, CE Broker, we work to bring together regulatory boards, licensed professionals, CME, CE providers onto one simplified platform. And we actually do share in the board's mission to protect healthcare consumers through the proper licensing and regulation of physicians and surgeons and certain allied healthcare professionals. And we share in that mission by really just helping to facilitate more efficient enforcement of CME requirements and help to streamline license renewal flows. Specifically, we would like to discuss addressing a key issue as outlined in the board's 2020 Sunset Report, which I know has already been brought up by a few previous commenters, being that the board did recently reduce its auditing percentage from 10% of the licensed population down to just 5%. And then later, due to COVID and a lack of resources, the board was actually forced to temporarily pause the CME audit program completely. And I think significantly hampering the board's ability to fulfill its mission. However, we can help solve this problem. We work with more than 135 state licensing boards currently, including the medical boards of Florida, Mississippi, New Mexico, Ohio, South Carolina, Tennessee, and Louisiana. And we are a proven and beneficial tool that is utilized around the country to more effectively administer and oversee those CME and CE requirements, audits, provider and course approvals, content management, and more. And so in light of this, our organization would love to actively participate in any way in those discussions involving the enforcement of continuing medical education requirements aimed at achieving higher rates of CME compliance amongst California physicians. And we would greatly appreciate an opportunity to showcase how we've successfully helped other agencies, other medical boards effectively audit and enforce those CME requirements at no cost. That's all that I have. Thank you.
Mr. Grubb, thank you for your comments. Are there any questions, comments from the members of the board or our executive staff? All right, seeing none, thank you, Mr. Grubb, and I think we'll move. Sorry, did someone
Yes.
unmute themselves?
Thank you. Yeah, I read your letter, and what I wanted to ask you is what it sounds like Florida Medical Board is your biggest one of the medical boards that you're doing. Maybe you cannot tell us this, but what is the what is that rate at which you are auditing there? Is it 5%, 10%, 15%? What's the percentage if you know that number offhand?
Sure. That's a great question. And the Florida Medical Board, you're right, is our largest client, and they actually fall under the umbrella agency of Florida Department of Health, which actually we do. We provide services for all of the boards under Florida DOH. I think that's 33 boards, and as an umbrella agency, they all are using us in a very similar way. And essentially, they use what they do is called enforce. It's called a compliance at renewal. And so essentially, when a licensee goes to renew their license, the state's licensing system will check CE Broker on the back end. And if they aren't current with their CME in CE Broker, then they actually cannot proceed with their renewal. So effectively, they're performing a 100% audit of all of their licensees. And I believe that's the case for all of those 33 boards within Florida Department of Health.
So are you like an intermediary that, the CME companies that are actually administering these CME or providing these CMEs, they then touch base or connect to your system, and there's the one database that it's all sitting in?
Yeah, that's another great question. And actually, we operate differently in different states. We always kind of tailor our services to what those boards' needs are. But yes, in Florida, those who are approved by the board to provide CE are reporting those course completions, those attendance rosters into CE Broker, and then the board has access to those to that completion data.
Okay, thank you.
Any other questions? All right, Sean, I think we're ready for the next public comment. Thank you.
Okay, next up we have Kristen Ogden. Kristen, are you there?
Yes, I am.
Please go ahead.
Thank you. I want to start by thanking the Board of California for engaging in an effort to improve transparency and public dialogue. I think that's tremendously important, and I appreciate the opportunity to speak here today. I am speaking on behalf of a small advocacy group called Families for Intractable Pain Relief. I personally am not a patient, but many of our members are patients and family members of intractable pain. I am the wife and caregiver to my husband of 48 years who has suffered from pain since he was a child and has suffered from true, incurable, intractable pain for much of his adult life. Our topic today is the urgent need to restore access to appropriate care for true intractable pain patients. I agree with the earlier commenter that the Death Certificate Project and the CDC's 2016 guidelines have caused a lot of problems for many people. In particular, they have caused a problem for the constituent members of my group who don't suffer from sort of routine chronic pain, but who truly suffer from almost unbearable, truly unbearable, constant, very severe pain. We have provided written comments. We sent a letter and attachments that sort of summarize some of our most important issues and recommendations for change. I would like, however, right now to speak to what I feel are the two overarching issues, and that is that many people in the general public, as well as legislators and regulators, do not acknowledge that severe, constant, life-altering, life-threatening, intractable pain really exists. It certainly does. Because my time is limited, I won't go into a lot of detail, but I have asked people at earlier presentations to just think about, if you think about the worst pain you've ever felt or could imagine feeling, and then consider what your life would be like if you felt that pain every minute of every day for years or even decades. That's the kind of pain that I am talking about, and that my husband and many others suffer from if inadequately treated. The second overarching issue is that the landscape in our country surrounding treatment of severe pain and the use of opioid pain medications to do so is extremely complex, fraught with much many concerns on the part of many parties, many driving forces, including dollars, fear, sometimes irrational fear of medications that have in fact been safely used for hundreds of years. As a general rule, physicians who practice nowadays as pain specialists, they do not treat pain really with the goal of making the person comfortable and enabling the person to have a decent, productive quality of life. Care almost always now is limited to invasive procedures and surgeries that are helpful to many people, but may not at all be helpful to folks suffering from the kind of pain I'm talking about. Pain medicine is, for all practical purposes, discouraged to the extent that it's almost not prescribed, it's almost not available. And the result of this is untreated and undertreated intractable pain that leads, in many cases, to a syndrome. Intractable pain syndrome, a predictable, life-threatening condition accompanied by measurable cardiovascular and endocrine dysfunction, can lead to heart attacks, heart failure, strokes, and premature death. The targeting of certain physicians who have sometimes prescribed high doses of pain medication for patients like I'm describing, unfortunately, those have been targeted in some cases, and the results led to the doctors being shamed and pressed out of service, patients being shamed and having a difficult time finding other care. The bottom line is that we do not advocate for or believe that there should be unlimited access to opioid pain medications for any and all complaints, but for people who suffer from a syndrome with predictable complexities that can lead to death, we think there should be much more flexibility. We want to see that the board and other parties can enable the resumption of medical management of intractable pain. One thing we specifically request is that we would like our group, Families for Intractable Pain Relief, to be included as stakeholders in your upcoming review of California's prescribing guideline. We would encourage the board to obtain education, a presentation on intractable pain and this syndrome, because we don't think Dr. Corey Waller's presentation really addressed that at all. We'd encourage you to do something a little different and hold a public meeting for pain patients and their families. Invite them to tell you what they go through. I know many, 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 many patients who would attend if such a meeting were called. And we would encourage you to establish a certification program for doctors to be able to treat these patients without fear of reprisal. Thank you very much for the opportunity to comment. I very much appreciate it.
Ms. Olson, Ogden, thank you for your comments. We appreciate them. And I just wanted to assure you that once the task force for revising the guidelines for opioids and controlled substances gets itself up and running, I think Mr. Persifka indicated that was going to be a 12 to 18 month process potentially, but let me assure you that they will be holding the type of meeting that you just requested. As one of the members of the board's cannabis task force, which is now sunset, we did exactly that type of meeting as part of the process. So I'm sure that they'll invite that type of input. Are there other questions, comments from board members?
May I
Dr.
comment,
Krause?
Ms. Lawson?
Yes.
I'm so glad that Ms. Ogden called. She's highlighted a major problem nationally. And I think it becomes a consequence of the way in which society and legislative bodies and boards are indeed reactive. If we go back in history a couple of decades, there was a great concern about physicians being neglectful of pain. And the pain monitor, from the happy smiley face to the sad crying face, rating pain from 0 to 10 was introduced as what we call the fifth vital sign. There was even a case in San Francisco where a physician was criminally charged for inadequate treatment of pain and charged with elder abuse. Physicians, by and large, are well-meaning and desirous of helping their patients, not just in curing disease, but in relieving pain. but physicians also respond to their own fear. So 20 years ago, when the physician community observed criminal charges leveled against physicians for inadequate control of pain, along with the legislature responded by requiring 12 hours of continuing medical education credit, and we all had to inquire about a level of pain, and we could not release a patient from a hospital or an emergency department until their pain was relieved. That led to the crisis of overprescribing pain medication, which we then reacted in pendular fashion by clamping down and creating cures and tracking prescriptions and doing coroner's reporting investigations. And this has led to a fear in the trenches on the part of the average physician that, gee whiz, if I prescribe an opioid medication, I may become under investigation by the board for inappropriate prescribing practices. So it's become harder for patients who are in true continuing need of pain relief to continue relationships with physicians who are reluctant to prescribe their necessary medication. And that's indeed why, in large part, we've convened this task force to find proper ways of balancing patient need, responding to patient pain, and easing up on the harsh restrictions we have on physicians who have withdrawn from adequate pain control because of fear of retribution on the part of the board or other regulatory agencies. So it's great that Ms. Ogden highlights this for us. And I'd like to be sure that she knows that the board has taken this in earnest and is working on the problem. And we hope to restore balance in the physician-patient relationship so that physicians feel comfortable in prescribing appropriately whatever may be necessary in terms of relieving pain. Thank you.
Additional comments from board members, executive staff? Excuse me.
May I speak? Madam President, this is Richard Thorpe.
Please, Dr. Thorpe.
Well, I think Dr. Krause is very well, so I'd like to take a moment just to comment on this issue, a couple of other, just to add to a couple of other issues as well. Dr. Krause is, and I appreciate Ms. Ogden's highlighting this, because I think as a primary care doctor, as a general internal medicine doctor who's taken care of a large number of chronic pain patients over the last 20 years, this is a very real problem. And in my community, there are very few doctors, if any, that will even consider writing opioid prescriptions unless it's Suboxone. And so I appreciate Dr. Khan's comments earlier today about the call to include CSAM in the opioid task force and revising the guidelines. And I've already, requested to Ms. Lawson, or at least I've offered my services to be on that task force as well. But the point is that, for hundreds of years, maybe even thousands of years, one of the few things that a physician could actually do for patients, long before we had any adequate treatments for prescription medications or surgical procedures, one of the few things that a doctor could actually do that was helpful was to provide pain relief. And that has become a very difficult path to walk currently because of the inappropriate use of medications by many doctors. And that's certainly, I'm not trying to minimize that, but the lack of recognition of this problem of chronic pain. It's now not only an issue with doctors, it's also an issue in the pharmacy community, because even if you do want to provide adequate pain control as a physician, you have a very serious hurdle to pass with the pharmacies, and even especially the large chain pharmacies. So I think there is a lot of work to be done, and I'm really encouraged that the medical board is seeking this path of reviewing the previous guidelines and actually creating a new set of prescribing guidelines that are actually equitable and address these problems in a very scientific and data-driven process that can actually really be helpful for those people that we really want to advocate for throughout the system, because you may not have chronic pain today, but there will be a time when you may have chronic pain, and the only answer for you may be narcotics. There are certainly other things. We have a much wider variety of things to offer now, but many of those things don't work. Many patients who have chronic failed back syndrome, where they've had multiple back surgeries, implantable nerve stimulators don't always help. And so sometimes the only thing that is available to them is some level of narcotic or opioid prescriptions. Just to get back to the other thing, I would like to just make a comment to also. The public comment is really invaluable. I said that earlier. I mean, I really believe that as I was going through my training, one of my chiefs of medicine said to me, Thorpe, he said, if you will just listen to patients, they will tell you what's wrong. If you listen long enough, they will tell you what the problem is. And I really believe that's true. I think that the tension in the process of trying to hear the public comments and to try to actually, one of the things that we clearly are there to protect the public, but part of public protection is making sure that the profession is viable and is strong. And I don't mean that to be protecting doctors. I mean to be without a physician community, if we make things so, and I'm not trying to say we should be soft on doctors, but doctors need to be included in this process of revising the medical board, so that there is this collaborative sense of doctors are part of that process and they want to do the right thing. I mean, most doctors really want to do the right thing. And I think that the idea that, and there are certainly, I'm not saying that all of them do, because I know there are some that don't, but I think to villainize every doctor as wanting to somehow harm patients is just not right. And we need to find a balance between making sure that we are very strong advocates. And I mean, Eric and Marion and Ms. Lauren, I mean, those are real, legitimate, serious problems that need to be addressed. And I do feel like sometimes I can't really respond to those in a way that's meaningful in the board meetings. So it's really helpful to get, and TJ and Lori have done a great job of interfacing there. I just don't want to give the impression that I don't care about that, or that I'm not interested in those concerns. I am. I really, truly am. But I think it's important to recognize that there has to be this somehow this balance of trying to make sure that we can encourage the physician community to trust the medical board as well. Because right now, I don't think the physician community trusts the medical board either. I think that's a real serious problem as well. So anyway, thank you for this time, and I appreciate the chance to be part of this stakeholder meeting. Thank you.
May I respond briefly?
Excuse me.
Dick causes me to reflect that my service on the medical board has placed me in a position where nobody likes me. The consumers don't like me, and my colleagues don't like me anymore. So much of the public thinks that we're here to protect doctors, but doctors are fearful of the medical board. And they quake in their boots when they get a letter of inquiry from the medical board about a complaint that's been filed against them. And indeed, this problem that Ms. Ogden has just highlighted demonstrates how legislative action and police action and medical board action has the potential to influence how the average physician practices. And we don't want the average physician to be fearful of adequately treating the pain of his or her patient. So we have to keep in balance that, yes, indeed, our mission is to protect patients from harm, but we also have to look at the downside of what we do and how it affects the day-to-day delivery of care. And it's not an easy path to walk. Thank you.
This is Alejandra. I just wanted to encourage us this is our opportunity to pass the mic to physician advocates. And I know we only have an hour left, and I would love to hopefully have as much time as possible to hear from them.
Yes, thank you.
May I comment, please, before my time is finished?
Please.
May I respond? I would just like to respond to Dr. Kraus and Dr. Thorpe to thank them very much for speaking up about this issue. And I have one final thought for the board. I understand and appreciate that you want to be thorough and include all involved parties in your project to revise guidelines. However, I would like to also say that I represent a couple hundred families, many of which did receive very helpful pain care for years or even decades, and now these same people are suffering. Is there a way that physicians who may no longer be practicing but are recognized experts in the care of individuals like I described can return to practice and take on these legacy patients that have documented lengthy treatment histories using opioids that would make such a huge difference? I'm 68, my husband is 71, and we don't know if he'll live long enough to see a return to the kind of care that really enabled us to have a very, very good life despite his illness. Thank you very much.
Ms. Ogden, I'm sorry, I just want to make sure I understand what that request was, because I guess I'd like some clarification. You mentioned, is there a way to have them return to practice? Are you talking about physicians who are no longer practicing, or are you meaning?
I'm talking about a particular physician who is no longer practicing, who is a worldwide recognized expert in caring for patients like my husband, and who practiced in California for a very long time. I would say he was encouraged to retire.
Yeah, I think I would just ask that you forward that information to our staff. You can, through the email address that it should be available on the website. Otherwise, it's webmaster@nbc.ca.
Yes, I have it. Thank you.
Thank you.
And Ms. Lawson, if I may?
Yes, please.
There is a process where physicians who have been disciplined and have either surrendered or revoked their license can petition for reinstatement. I think that's what Ms. Ogden is getting at.
Okay.
And so that information is available to those phisians.
Great, thanks.
On the website.
Ms. Webb, yeah. And again, Ms. Ogden, I would just invite you to contact our staff directly for more information. I want to stay away here from talking about any particular physician circumstance. Thank you. All right. Any other comments? Otherwise, let me just do a check-in. Sean, do we still, by my count, there should be 10 left in the queue, but there might have been ones who were added.
Yeah, there's 11 now.
Okay.
Just,
so,
kind of people keep adding.
So in the interest of time, I would like to try to make sure we move through these as quickly as we can, so we get as much input as we can during the allotted time. So I would just ask the board members to be judicious in your comments or questions. And if there's something you would like a follow-up on, I'd like us to just invite the public as well to, also provide comments that we can receive electronically and follow up on. But I want to make sure we get to everybody. And so I would invite as well the members of the public to just try to be judicious with your time as well. Sean, let's move to the next public comment.
Shelley Carter, are you there?
Yes, good morning. Can you hear me?
Please go ahead. Yes, we can. Please go ahead.
Great. Good morning. I'd like to thank the board for this opportunity. My comments will be very brief. I am a trial attorney. For 10 years, I did medical malpractice work. I now do medical staff work and do peer review work. I am also the immediate past president of the California Association of Attorneys for Healthcare Professionals, the Academy. And I am not speaking on their behalf today, except to introduce them as an organization of attorneys across the state of California who represent physicians and other healthcare professionals before the licensing boards. And we represent independent medical staffs in peer review matters. I truly appreciate all of the comments, both from the people who've spoken, from the public who have individual concerns, and as well from the board members. And I think the comments about balance personally really hit home, and I really appreciated Ms. Gramme's presentation this morning. I'd like to thank you for the opportunity to dialogue, and I hope that members of the Academy will be able to do so in the future. That's all I had to say. Thank you.
Thank you. Are there any quick comments or questions? All right, Sean, it looks like we can move to the next public commenter.
Okay, next up we have Hannah Reed. Hannah, are you there? Hannah, I can hear you in the background. Are you ready to make your public comment? Okay, we're moving on to Lee Wolfer. Lee, are you there?
Yes. Hi, can you hear me?
Yes, please go ahead.
Hi. Thank you, Madam President. Thank you to the board members, the executive staff, and everyone present on the call. I was unaware of the format, so I don't have a perfectly written statement, but I will stick to my allotted time. My concern is about the quality of the expert witnesses that the board retains to review cases. I have a particular interest in the expert witnesses assigned to review doctors' cases. I also, before I say more about this, as a doctor, the first most important duty, I think, of the board is, hearing these stories of seriously injured or, killed patients. And I'm glad their voices go first. I do believe that this is an issue that, however, affects both patients and physicians who are disciplined by the board. My concern is that there is an inadequate vetting process of expert witnesses. I researched my own expert witness and found that she'd been terminated. I will not use her name, for gross misconduct, which included leading to the death of a patient. There were 2 805s filed. From what I understand, the board is out of compliance with AB 1886, where 805s are supposed to be listed indefinitely. At the time of this expert witness's termination from her employment, she was working as a board expert witness. She had been for 5 years. And then she was ultimately terminated, and she received no discipline from the board. There were extensive episodes of really gross professional misconduct documented, and her case was dismissed with no public discipline, no public letter of reprimand. And then, according to her CV, the only punishment that I could detect was that she was not allowed to work as an expert witness for 3 years, and was reinstated in 2014. And under the guidelines of expert witnesses, you're not to have any prior complaints within the prior 3 years. During that time, 2 serious episodes of what I would call errant conduct behavior occurred. And I believe because of a lack of data use agreements, that the board either never received these documents or just did not take action. It certainly, unfortunately, gives the appearance of protecting this witness. A civil commission, which ultimately put out a 52-page report, had 85 exhibits, 11 witnesses, upheld her termination for endangering patients, failure to collaborate, insubordination, etc. That report came out in 2012. I don't believe it ever got to the medical board. Also, the patient or the witness tried to sue her prior employer in a particular county and was able to obtain records from her prior psychiatric patients that she cared for years earlier and surreptitiously snuck their phone numbers, cold called them, and tried to get letters of reference from them to help with her ongoing legal battles. And a declaration was submitted to one of the local superior courts by a coworker. And I don't believe that declaration ever reached the board. In addition, it's come to my attention that she perjured herself on her California medical license, failing to disclose a DWI.
Did we somehow lose that commenter?
I still see her in the WebEx application. The mic is still open, but yeah, it sounds like maybe she lost the connection. Looks like she was connected from a mobile device, so I don't know. Maybe she dropped off.
Okay, I guess to the
Case is at
extent
risk.
it looks like
Sorry,
we're
go
having. No, unfortunately, it looks like we're having some audio problems hearing from you. You were cut off there.
Yeah.
I'm sorry.
Sorry, an incoming call came in. Did I get cut off during that time?
You did get cut off during that time, so we missed a piece of what you were saying. But because of the time limitation, what I would invite you to do, if to the extent you haven't already, is submit these comments in writing so that we can take a look at the specifics of the cases that you're referring to.
I submitted all of this, and the
Okay.
case was closed in 24 hours under a different board president. And if perhaps I just maybe Attorney Gramme could, or one of you could comment on whether an 805 from 2009 is required to be posted on the board website, because had I been able to find this information, I would have requested a different expert witness on my case. I believe that her impairments led to sort of an inadequate expert report. So I just am, again, basically the big question is how you vet expert witnesses, how you make sure they maintain CMEs. And just one last point, and then I'll be quiet. This physician couldn't find work anywhere for the last 11 years, has worked as San Quentin on death row. And I just can't even tell you what that experience was like, being interviewed by someone who specializes in psychiatrically ill patients on death row. It's not a great look for the board. And she now advertises as an expert in jail suicides, and there have been 8 suicides at San Quentin since she's been there. So there may be ongoing harm. Thank you.
Thank you for your comments.
Ms. Lawson?
Yes.
The board posts 805s consistent with Business and Professions Code section 2027 B7. So there's very specific requirements on what 805s may be posted.
Thanks, Ms. Webb. Are there any other questions or comments? Sean, if we could move on to the next commenter.
Okay, next up we have Jen Camel. Jen, are you there?
Yes, I am. Can you hear me?
Yes, please go ahead.
Thank you. Good afternoon, and thank you for creating this venue. I'm Jen Camel, founder, CEO of VBAC Facts, a free client. Our mission at VBAC Facts is to increase access to vaginal cesarean feedback, as it is an action supported by national guidelines in the medical literature. Today, I represent thousands of birthing families throughout California when I express our support for a licensed midwife board, which will resolve the current regulatory stalemate that revolves around VBAC. Right now, access to VBAC with a licensed midwife in California is held hostage by regulatory capture. And we can't stop the regulatory capture until we end the medical board regulation of midwives. As long as the medical board regulates midwives, limiting VBAC access will be on their agenda because fundamentally, the medical board is beholden to the California Medical Association and the American College of Obstetricians and Gynecologists, which is a direct threat to people who are seeking VBAC care. CMA and ACOG's combined money, power, and cultural authority afford them disproportionate influence as stakeholders when it comes to the medical board's regulation of midwifery, which begs the question, whose voices are lost? Members of the public, who the medical board is charged to protect, and people like me, who had to learn to do their own research to identify and neutralize the misinformation many OBs provide about VBAC, which contributes to an 85% repeat cesarean rate in California, even though the evidence and national guidelines are clear. VBAC is a safe and reasonable option, which should be available to virtually everyone pregnant after a cesarean. CMA and ACOG's ongoing efforts to ban VBAC with licensed midwives ensures their medical monopoly because only OBs perform repeat cesareans, midwives don't. So where does this leave the autonomy of pregnant people if you have a medical board dominated by a profession that is consistently denying pregnant people the right of full access to midwives and out-of-hospital births? That's the paternalism, the implicit bias, regulatory capture. It's all intertwined, and it ultimately hurts the public. The medical board is failing its mission to protect the public because it is not properly equipped to regulate midwives. They will always be swayed by CMA and ACOG, who do not represent the public, but rather the concerns of the medical lobby, whose paternalistic rhetoric about the decision-making capacity of midwifery clients fuels the push to deny them alternatives to forced repeat cesarean surgery. As a result of the undue influence of CMA and ACOG, for the medical board, personal decision-making around health care ends at midwifery care, VBAC care, and out-of-hospital care. The solution to this assault on the autonomy of birthing people is a licensed midwife board. Thank you for your time, for holding the stakeholder meeting, and for elevating the voices of the public. Through the medical board listening to, truly working in collaboration with the public, without the influence of medical associations, I think the medical board can move closer to satisfying their mission of protecting the public. The interests of the public are very different from the interests of medical associations. Thank you again for listening.
Thank you, Ms. Campbell, for your comments. We appreciate them. Are there any questions or comments from other board members? All right, let's move on to the next public commenter, please, Sean.
Okay, and just for an update, I see 9 now in queue. Wendy Necht, are you there?
Yes, I'm here. Can you hear me?
Yes, please go ahead.
Hi, I want to thank you for the opportunity to speak today. And also want to thank the board for the support of our proposed legislation, AB 1278, which is all about transparency and making sure that patients have all the necessary information to make an informed decision. And I also want to thank Center for Public Interest Law for sponsoring that legislation as well. And I agree with most of the advocates and all the comments and suggestions, and I try not to repeat things. I've submitted everything, so you'll get this. But in order to gain public trust in the medical board, we hear over and over, we need transparency, more transparency. And when I say public trust, I'm talking about patients and doctors, because I think good doctors see how long it takes for a bad doctor to be disciplined, and they don't really take the board that seriously because nothing gets done. And this is just conversations I've overheard. But anyway, I have some suggestions regarding transparency. And as you know, where there's transparency, there is accountability. And where you have accountability, you have not only greater efficiency, but you have greater truth. So that's something that I think is pretty clear that everyone agrees on. Regarding the investigative process, I think it's really important that we allow an exchange of documents so that the complainant is also privy to important document protection. As it stands now, as you know, complainants are completely left in the dark as to the status of their case in the investigation. So all documents should be able to be viewed by either party. And the lack of transparency can pave the way for lying because there's no accountability, inaccurate findings, it wastes valuable time, and it critically, also reduces the public trust in the board. So my suggestion for this is to create a secure system, which it sounds like you're working on, so that when the complainant is given a case number, they're given a secure sign-in. And one thing I would really direct you to is the USPTO, the Patent Office. When you apply for a patent and the patent's being prosecuted, you get a number, that you get a sign-in, and then at any time during the process in that portal, you can see exactly where your case is. You can see what documents are needed, what documents have been retrieved, what the next steps are, and everybody knows where their case is. You can see the documents, and I think it would be a really good model for you guys to look at. In that way, also, if anytime a document is requested or entered into the system from either side, it's accessible by anyone involved in the process. So most importantly, investigators, doctors, and the complainant would all be accountable to one another, encouraging truthfulness. Implementing a system like this would be greatly effective, and I really hope that you'll take a look at that. Also, make all complaints visible to the public. There's no reason, and I know this has been suggested before too, why a citizen should be able to find out complaints registered against their contractor or their financial advisor, but not their doctor. The public not only has a right to know, they have a need to know. If a board's mission is truly to promote access to quality medical care through the board's licensing and regulatory functions, then this kind of transparency shouldn't be an option. Not disclosing these reports and forcing the public to rely on Yelp reviews for accurate information is really a disservice to the citizens of California. And also, another suggestion would be better vetting of initial complaints. So when you consider all the effort that it takes for somebody to complain to the board and the extraordinary circumstances that motivated their complaint, I really believe they deserve better consideration. Seems to me that the board needs more qualified personnel, both in numbers.
30 seconds remain.
Excuse me?
30 seconds remain.
Oh, sorry, that went fast. Sorry. Well, I've written up everything, and I know some of it is legislature. I'm just gonna, the 3 to 4 settlements in a 5-year period, that hopefully that will be legislation that will move forward. And I also wanted to say that I really support the Center for Public Interest Law's suggestions about establishing a public majority member on the board, appointing an enforcement monitor, creating an ombuds office, and increasing licensing fees. But it's all in what I've written up. Thank you.
Great. Thank you so much for your comments. We appreciate you taking the time. Are there any comments or questions from board members or from our executive staff?
I have a quick one, Madam President. Clarifying question for staff. And as a patent attorney, I can attest that the PTO site does do that, and it's pretty easy to use. It's not public though, so it's only for the, for the patent
Right.
applicant and
Exactly.
with the PTO. But on our side, what are the biggest hurdles to getting something like that? Is it on the legislative side? Is it the cost, the technological hurdle to get it up and running? Just wanted to get a little insight on that.
Are you asking me? No.
This is Carrie. I can assist. Breeze was supposed to provide this type of access, but there is a concern about how to maintain confidentiality on the documents and information that must be maintained in a confidential status based on statute. But that being said, as Mr. Prosifka indicated, staff is continuing to work on this to determine how to provide access at the points and with the information that the board is allowed to share. So right now, complainants get letters at different points. So at a minimum, the system ought to be able to provide those checkpoints in an online fashion. So that's the project that's currently being worked on.
Thank you.
Thank you. Any other questions or comments? All right, Sean, it looks like we can move on to the next public commenter.
And next up, we have Billy Early. Billy, are you there?
Yes, I'm here. Can you hear me?
Yes, we can. Go ahead.
Hi. Hello. I would like to thank the medical board and Bridget, or the Centers of Public Law for holding this important. Gonna take this off speaker. Sorry about that there. For holding this important meeting, public meeting, giving us the opportunity today to possibly help the medical board vision, gain consumer and public confidence. My name is Billy Early. I speak 3 languages. I was the former owner of First Choice Clinica Familiar. I'm a national advisor for Black Doctors Matter, national advisor for the American Pain Institute. I'm an advocate for the World Sickle Cell Federation. I'm an ambassador for Doctors of Courage, and I was a congressional briefing panelist in Washington, D.C. in 2018 on DOJ corruption. Out of respect, I would like to take a brief moment to honor the late, respected Dr. Ronald B. Myers, Sr., founder of Black Doctors Matter and founder of the highly Black celebrated day called Juneteenth. Dr. Myers' license was taken because he started Juneteenth, and he died poor and he suffered. Black Doctors Matter. I attended and commented on the Sunset Review hearing on the Medical Board of California, and I informed the review committee that the medical board conducts over 10,000 investigations each year, which is 85% controlled and guided by the state police and the Department of Justice prosecutors. In light of George Floyd's verdict, the medical board should and must exercise more caution when dealing with a large, hidden police department. A lot of doctors and patients are victims to state police and DOJ misconduct, and these investigative misconducts and crimes are widespread and without accountability. I have something very sensitive that I would like to share with the board on behalf of Black Doctors Matter. We sent a public open letter to the former medical board president and board members demanding an investigation into the death of Dr. Anthony Jackson, a Black role model for the community. Dr. Jackson fought hard for his license and respect. He won his case in the appellate courts. Dr. Jackson sued, or he wanted to sue the medical board and create a civilian review committee to help those falsely accused. Dr. Jackson met with a large group of community stakeholders. He met with the American Political Association, the American Black Political Association, He met with the Golden State Medical Association, the National Medical Association, the Action Network group with Al Sharpton's group. And the meeting was also attended by Cassandra Hawkinson, a medical board public information officer. She was there at the meeting. 2 days after the meeting, Dr. Jackson was dead. His wife or his girlfriend stated that his death was very suspicious and she suspected foul play. 2 months later, Cassandra Hawkinson, the medical board information officer, died mysteriously according to her own family's testimony. Cassandra also worked at CBS News and as an investigative writer. She was an investigative writer for CBS News. She was working on a big story, from what my understanding is, before she suddenly died. These alleged crimes involved the death of a medical board worker and a human being. Harvard University and other researchers have recently published that Black doctors in the state of California have reached critical low numbers, and Dr. Anthony Jackson, myself, and many other doctors of ethnic color are targets of massive state police
30
and
seconds remaining.
DOJ corruption. Okay, thank you. I think this board is heading in the right direction by allowing the public to comment and start a platform advocating for patients and doctors exposed to DOJ, state police, and other types of government corruption. The medical board should and must provide and seek remedies for doctors who were exposed to DOJ and state police crimes. Yes, there are a lot of bad doctors out there. I hear people and I feel their grief and their rage, but there are also a lot of good Black doctors who are being wrongfully targeted and even taken out by these groups of crooked people that are functioning with impunity inside the medical board. Well, I don't know if they're state, they're contracted police officers, maybe they're inside the medical board and
Please
DOJ
conclude.
personnel. Okay, that's all I have to say. Thank you guys for allowing me and the public to comment.
Mr. Early, thank you for your comments. Are there any comments or questions from the members or executive staff? Right, thank you.
Dr.
I'm sorry. Go for it.
Yeah, just briefly comment. Dr. Anthony Jackson I knew very, very well. He was part of our medical society, and actually, for no small part, I'm on the medical board because of a person that he put me in contact with, one of the staffers of Senator Feinstein, the late Percy Pinckney. Dr. Jackson actually was responsible in large part for the disciplinary guideline study that we adopted and have presented under Kim Kirchmeyer's tenure. Dr. Jackson did the board a great service and a service to consumers and physicians in the state of California.
Thank you. Are there any other questions, comments?
Just a quick question.
Please.
I just wanted to encourage Dr. Early. I don't think I've seen any submission yet. So if you haven't, I'd welcome to read anything further.
Okay, thank you.
Thank you.
All right, other questions, comments? All right, Sean, next commenter, please.
Next up, we have Virginia Farr. Virginia, are you there?
Hi, thank you for holding this meeting for us.
Virginia, you have an echo going on in the background? Is there a speaker or something going on? Yeah, thank you very much. Go ahead. Yes.
No, I can't.
Maybe if you just turn it down a little bit, it won't produce such
Is
an
that
echo
better?
when you're talking. It sounds good right now. Yes, thank you.
As if I can't hear you. So I'm a patient. I've lost over $1 million due to medical errors by 1,000 cuts. So my medical errors would likely not do anything to the doctors, but it's still very impactful for what happened to me. Since they talked about pain, I would like to talk pain just for a minute. Another perspective. So I had intractable pain for 3 years in which I could not sit for more than a couple minutes. And every time I went to a doctor, I was prescribed medications and they never figured out what was wrong. A doctor in Arizona figured out what was wrong in like half an hour. I've been pain-free since then. So it's important to know that a lot of times you're not properly diagnosed. They are not properly diagnosing pain, and there is a solution, but they're not taking the time or have the knowledge to figure it out. Secondly, my Most accurate H&P is from 2010, UCSF. John Muir refuses to produce an accurate H&P because of all the medical errors I received at John Muir Health. When I tried to add my addendums, they took me off Epic, and I'm no longer able to write messages that way. I can continue to experience medical harm because of this. It took me 6 years to go back to the doctor after the first harm. And then I experienced another medical error that cost me $5,000 after already losing $1 million from medical errors. So I'm really concerned about patients being able to make accurate medical records. Also, we have a lot of trauma, and it'd be really nice if the medical board was trauma informed and understood trauma and responded to us in a trauma informed manner. And lastly, regarding MICRA, it's really concerning to me that College 101 is the risk and benefits of stuff and figuring out a solution instead of just eliminating one option. Your board member has is mass harm. People have committed suicide from MICRA. I've lost $1 million. I have PTSD from it. And people on your board are allowed to advocate for this and still have their license, even though they cause mass harm. And it's highly concerning to me. Like, I don't care if he's a member of the medical association, that should not be an okay to cause mass harm. And that's all I have to say.
Barth, thank you for your comments. And I just wanted to say how much I appreciated the comment you made about being trauma informed. And we do try to educate ourselves on a variety of issues, but you've highlighted one where we haven't educated ourselves as a board and had that as a meeting. And so I'll take that away, and perhaps that's something I can work with staff to schedule in an upcoming meeting. Are there any other comments, questions from board members?
Alejandra, just that I echo that and would look forward to that training.
Thank you.
And it should not only be the board, it should be doctors in general, because when people with trauma go to the doctors, they don't have the window of tolerance to deal with what's put in front of them after so much trauma. Like, I go into freeze as soon as I walk into a doctor's office because I can't talk anymore. And I just get harmed again and again. So doctors need to understand trauma, especially medical trauma. And I would like to somebody comment on the medical records and not being able to get accurate medical records.
With respect to that comment, Ms. Farr, I would invite you to submit those specific comments in writing, so it's something that our staff can review and take a look at, and then we can better advise you as to that.
But in general, patients need to be able to like open notes. We need to have ability to do that. So a law needs to be changed, and we're unable to change it, as most people said. So I will submit that, but that needs to change. Because if you say you had a medical error, the doctors ignore what you say, put down their pen, and no longer engage with that specific part of your health records. And I also like you take to note that people who advocate for MICRA should not be on the medical board or have a license because they're causing mass harm. So that's it. Thank you.
Thank you, Ms. Farr, for your comments. Any other questions or comments from staff or the board members? All right, Sean, how many commenters do we have left on the call?
We have 8 currently in queue.
Okay.
And again, I see some people putting their hand down and raising it back up. All that's doing is moving you to the bottom of the queue. Just trust if your hand's up, we're calling you on the order that they were raised. So.
Okay, and I guess are we? I don't want to cut off anyone from making a comment, but we do have a stop at 1 p.m. So I would just ask people to get in the queue right now if you'd like to make a comment, and we'll try to get through these as best we can.
And I'm making sure there's no double, comments or anything like that.
Sure,
so these are all
fair enough.
people that have not spoken yet.
Yeah.
Should we proceed? Okay, next up we have
Please.
Tina Hildebrand, please. Tina, are you there?
Hi there. Yes, can you hear me?
Yes, please go ahead.
I will apologize. I am on the train, so if there's background noise, I'm sorry for that. But I appreciate the medical board putting this together and listening. I have to say it's the first time that I really feel that the medical board is listening, and probably because you're allowed to respond to us, which, as we know, is not available in public comment. My comments, and so I am Christina Hildebrand. I'm the founder and president of A Voice for Choice Advocacy, which is a organization that educates and advocates for informed choice and transparency of what goes into your body, be it food, air, water, pharmaceuticals. We were not involved with the medical board until 2015 when SB 277, which was the vaccine mandate law, came into play. Since then, I have attended probably every medical board meeting, and I usually make comments, so most of you probably know me. I deal with vaccines, which, when I mention that, makes people very defensive. It is a toxic word for most people, especially our legislators. With COVID, it's interesting to have seen how even more polarized the word vaccine has become. And how political the word vaccine has become. So I ask you all to take a step back and think of vaccines as any other medical treatment. I could be using the word opioid. I could be using the word antibiotics. And that's how I ask you to listen to me, with that frame of reference, that it is a medical treatment, and every medical treatment has side effects. Every medical treatment, every drug has people that cannot tolerate that medical treatment. So in 2015, medical vaccines in schools were only allowed with exemptions for medical exemptions, so for medical reasons. There are a number of doctors who wrote medical exemptions, and in 2015, the law was extremely broad and said that it was up to the doctor's discretion to write medical exemptions. What happened after that is that there were and I will say not many. I mean, there are 150,000 licensed doctors in California, and not many of them truly understand vaccines and the harm that vaccines have. And we will come in, so hopefully you heard me. But the one thing with COVID that we have seen is that many, many more people are aware of VAERS, the Vaccine Adverse Events Reporting System, and that there are people who have adverse events to vaccines. That's, it's a known thing for any medication. Vaccines are no different. So the doctors started writing medical exemptions based on including things like sibling history, family history of vaccine reactions. Those doctors have now all been witch hunted, and they were witch hunted regardless of whether they did good or whether they understood what they were getting into. They have every single doctor that has written a medical exemption has been witch hunted, not necessarily by the medical board, but by nurses, other doctors who basically don't feel that there is anything wrong with vaccination, and that everyone, 100% of the population, should be vaccinated, and that it is 1 in a million chance of having a reaction. With the COVID vaccine, we've seen it's not 1 in a million. Mainstream media has shown us it's not 1 in a million. These doctors are who we come to you because of, not the doctors, but the consumers that are on the other end of that. Most of these doctors have gone above and beyond in studying vaccinology, in studying adversonomics, which is basically vaccine reactions. They're using the most current research and data. They are, what I would consider the Mayo Clinic in cancer research, or St. Jude's in cancer research. These are the doctors that have been studying adverse reactions, genetics, autoimmune disorders, how they link to vaccines. Sorry, yes?
30 seconds remaining.
Okay. So I guess I come from the other side. Sorry, I spent a lot of time on that. Didn't realize it's so slow. But I come from the other side where, many people are saying that doctors are not being prosecuted, whereas we're seeing numbers of doctors prosecuted, and very quickly prosecuted, by the Medical Association. And I'd like to see some consistency there, and for the medical board to really look at standard of care versus these doctors that are going. It's kind of like the opioid crisis, honestly, is what the person who spoke on opioids. Some suggestions I have is getting legislation passed is close to impossible as a consumer advocate unless you have a lot of money for lobbying, et cetera, et cetera. If the California Medical Board came behind some legislation or requested legislation, that would make it much more likely that legislators would pick it up. The other thing that I would say is your association with the California Medical Association harms patients, harms consumers. Your link there, they have millions of dollars that they put into the legislature and lobbying every year. So I ask you to maybe look at that and distance yourself from them, or possibly look at how you interact with them. The last item that I request, which we have requested at nearly every medical board meeting, is that there is an agenda item. You know, we request agenda items every meeting, that the agenda items that we request, that one agenda item per quarterly meeting is set aside for consumer advocates to present something to the board, and that the board takes that in, because that way we can have the open communication with you. I have more. I will send it to you in an email, but those are my comments initially.
Ms. Hildebrand, thank you for those comments. Just one thing to note, I know that Dr. Hawkins, Ms. Lubiano are really working to get the I may get the name of the committee wrong, the Public Outreach Committee back up and running. And I think they will be taking a look at this. Your last point about including some type of opportunity on each of our agendas, actually to have a conversation maybe like this, right? Where there can be some back and forth, or an opportunity for stakeholder groups to present on items of interest to them. So I think that's something that will work its way through the Public Outreach Committee, perhaps, because as you've identified, and frankly, I think as the board members, we share your feeling. The public comment period is restricted in terms of what we can do. The requirements we have for putting items on the agenda restrict the kind of back and forth communication we're having in this type of meeting. So Dr. Hawkins, I don't know if you have anything more to say about what that committee might be doing, or timing of that work, but I believe those are the types of things you're going to be looking into.
That's accurate, and we'll talk about it at the next quarterly meeting. We'll do a presentation. Thank you.
Terrific. Thank you, Dr. Hawkins.
Thank you.
Are there any other questions or comments? All right, we are running very low on time. So Sean, can we try to limit the amount of time for each commenter going forward so we get close to that 1 p.m. time?
What time would you like me to give them a warning?
Were we currently giving 5 minutes or 3 minutes?
5.
Okay, let's give maybe 2 or 3 minutes so we can try to get as many people as possible. And like I said at the outset, I know we've been re-emphasizing this, but we really do encourage you to submit comments in writing, and we will have more of these forums in the future, as well as our upcoming board meeting. So Sean, let's proceed with the next commenter.
We'll give audible warning at 2 minutes, and we have 9 in queue. So next up, we have Carrie Parker. Carrie, are you there?
I'm here, thank you. Yes,
Please go ahead.
Thank you. My name is Carrie Parker, and I am the former executive director for the California Society of Addiction Medicine. I retired last year, and I'm here today because I remain concerned that our state can have a statewide physician health program. And over the last couple of decades, actually, I worked with a number of stakeholders on this, something that we all believe very strongly that our state needs to have, similar to what other states have operating effectively. Back in 2016, Governor Brown signed a bill, SB 1177, which authorized the medical board to establish its own physician health and wellness program. And it was designed specifically to identify early identification of appropriate interventions and to support physician rehabilitation. So according to the medical board schedule, the program was to be, this was in 2017, was to adopt regulations, issue an RFP, and then another second set of regulations to set a fee for the program. But however, about 3 years have now gone by, and now I'm no longer working, but I am a consumer and I'm a stakeholder, and I am concerned that the slowness to put in place a program is potentially hurting the public safety. And so I'd like to see more speed moving toward getting a program in place. There have been a number of documents that have been presented previously to the medical board on what would constitute a well-developed program, and also how to
2 minutes, please. Conclude.
So how to do so with keeping in mind what would protect the public. Today, I just want to mention a couple of solutions that I think were brought out and I think can work to hopefully move this along. I think that the idea of an ombudsman would be very effective in helping people understand, once these kinds of services are available, what's the right path for them. And so I definitely applaud that idea. I also would welcome Dr. Hawkins reigniting the wellness outreach, and I think that's wonderful, and this obviously would fit right into that. And also, I think where possible, where CPIL and the medical community can find some common ground around this type of program, I think that would be very, very beneficial to sort out some of the operational issues.
Please conclude your comments. That's 3 minutes.
Some of the operational issues that have hindered getting this up and running. So again, just thank you for the time. I just would like to see this program get underway. And if I can be of any help in doing that, I'm standing available to help the board. Thank you.
Thank you for the comment. And at this point, I'm going to ask that we just move on to the next public commenter rather than inviting comments and questions from the board, if that's okay with everyone. All right, thanks, Sean. Go ahead.
Next up, we have Olivia Villers. Olivia, are you there?
Hi, yes. Can you hear me?
Yes, please go ahead.
Thank you. Hello to everyone, and thank you so much for your time and the opportunity to speak. I have a very brief message to share with you all on behalf of Dr. Sherry Afai, who is a cannabis medicine physician, and that is that it is now time to change the cannabis guidelines for recommendations for physicians, as they are outdated, predating the adult use and recreational laws, and they need to be redone. Dr. Yafai and the Society of Cannabis Clinicians would be happy to assist in the process, and just wanted to make sure that that was on the radar. Thank you.
Thank you. Sean, can we move on to the next public commenter?
Yes, next up we have Karen Mioto. Karen, are you there? Karen Mioto, are you there? I see you muting and unmuting, but we're not hearing you.
Now?
Yes, go ahead. We can hear you.
Oh, yes. Dr. David Kahn, I'm speaking on behalf of the California Society of Addiction Medicine. I'm the president-elect and the chair of the CSAM Committee on Physician Health. I will follow through with collaboration, the kind that Dr. Kahn and Mr. Pacific talked about, in the areas that we have clinical experience and expertise, and look forward to being of assistance. Thank you.
Thank you for your public comment. Next up, we have Teresa Yu. Teresa, are you there?
Yes, can you hear me?
Yes, we can. Please go ahead.
Great, thanks. Good afternoon. My name is Teresa Yu, and I'm the board president of California Families for Access to Midwives, which is a consumer advocacy organization with over 5,000 supporters that advances access to midwifery and other birth options for consumers. We strongly support the sunrising of a licensed midwife board under the 2021 Medical Board Sunset Review. Licensed midwives are the only healthcare profession in California not overseen by a board of their own peers or consumers who utilize their services. We are aware of the long history of paternalism and sexism that had almost ended the profession of midwifery and continues to have a male-dominated profession control a female-dominated one whose patients are almost entirely made up of women. This medical board has not been able to adequately oversee licensed midwives. Physicians do not understand midwifery care and the midwifery model. They are in fact biased against midwifery, and physicians through CMA and ACOG are the very profession that is curtailing autonomy of midwifery consumers through recent legislation. Through the medical board, they're inadequately regulating midwives as well, for example, by indiscriminately referring all complaints to full investigation. It is against the public interest for licensed midwives to be continued to be overseen by the medical board. Besides the neglect and ignorance of midwifery, it is marginalizing the voices of consumers and minimalizing their experiences. Consumers like myself who chose licensed midwives have very intentionally rejected OB-led care, often paying thousands out of pocket for this option. Some were very dissatisfied by previous physician-led hospital birth experiences. Many want to avoid medical interventions when they can be avoided and want a personalized client-centered experience in a community setting, one where they have a provider who they have built a relationship with who is guaranteed to be at their labor or birth. We want care that adheres to a midwifery model and do not want our care providers overseen and undermined by a physician board. We ask that you hear what consumers want and support their right to personalized decision-making around healthcare. A licensed midwife board would ensure high quality of care through oversight from professionals who understand the practice of and standards of community-based midwifery care. Thank you for your time and consideration.
Thank you for your comment.
Next up, we have Michelle Montserrat Ramos. Michelle, are you there?
Yes, I am. Good
Please go ahead.
afternoon. My name is Michelle Montserrat Ramos, and I'm with Consumer Watchdog. In order to give a little background for the new board members, I attended my first meeting back in 2005 when I was preparing my consumer complaint. My complaint included 2 autopsy reports, including one from the LA County coroner. It included arrests, including one for felony possession of crack cocaine. It included other victims, and it included an admission by the doctor that he had changed his medical records, yet Lloyd Montserrat's case was not worthy of investigation. My complaint was dismissed at the Central Complaint Unit with no communication with me. Lloyd Montserrat was a political star in California, but his life meant absolutely nothing to the state and to the board. This motivated me to advocate for change with this board 16 years later in order to help other families. In 16 years, I have pushed the board to implement a teleconference line to help the public engage with you. It took years to do this. I was one of the 3 consumers who advocated for the end of the former diversion program because it failed consumers. Lloyd's story of his death by a substance abusing physician led to the author and passage of SB 1441, the Uniform Standards for Substance Abusing Healthcare Professionals in the state. It is one of the few pieces of legislation that holds physicians accountable. I also lobbied for 2 years for the passage of SB 1448, the Patient's Right to Know Act. At the last strategic planning session, I made several recommendations that were rallied by public board members. Ms. Lawson may remember this, but were later dropped and not included in the strategic plan. The consumer complaint process and the investigation process is difficult for consumers. Families need to make sure their voice is heard in the enforcement process. In order to do this, we need you to interview the family before you dismiss a case at the Central Complaint Unit. We also need you to talk with the family following the physician's interview so that the family can respond to the physician's comments. This will save your staff time, and it will give the family a voice. So if the case is ultimately dismissed, the family will feel that they actually had a voice. I have asked in the past that you use your medical experts training materials to create a video to show consumers exactly what you're looking for in a consumer complaint. The process is difficult, and families need to know exactly what you are looking for. The board staff is not communicating with families. The families I work with, which are families that are across the state of California, are not receiving letters from you. Your staff does not return emails or phone calls. I have had one family that cannot get a guarantee that their consumer complaint has been given to the consultant who is reviewing it. The family's voice is not being heard.
Please
As I
conclude.
mentioned, I work with families across the state, and I cannot find one single family that has had a positive outcome with the board, including me. We can do better. We are here. I am still here 16 years later to try to improve this process so no Californian has to endure what I have and what many other family members you are hearing from have. Please implement these changes. Thank you.
Ms. Montserrat-Ramos, thank you for your public comment. Are there any questions or comments from board members? It's 1 p.m. Sean, can you tell us how many commenters we still have in the queue?
5 remaining.
All right, let's try to proceed to make sure everyone has an opportunity to provide their comment on the record. If we can't get to everyone, we'll again invite you to submit your comments in writing. But I do know that there are some folks who were counting on this ending at 1. So I'd like to be respectful of that as well. But let's try to get through these 5 commenters.
Natalie Diaz, are you there?
Yes, can you hear me?
Yes, please go ahead.
Great, good afternoon. This is Natalie Diaz and I'm with the California Primary Care Association. Thank you, board members, for your time. I wanted to raise an issue that we, alongside the California Medical Association, California Academy of Family Physicians, and SEIU have brought up at previous board meetings, which is the unintended consequences of the changes to physician licensing created under SB 798 at the last sunset review. Prior to January 2020, residents received their unrestricted license after 12 or 24 months of residency training as a respective domestically trained or international medical graduate. During this time, they could enroll as Medi-Cal fee-for-service or managed care providers and bill for moonlighting services. Federal regulations provide that Medicaid providers must not have current, restrictions on any limitations for their license. And because the PTL is a restricted license, thereby PTL holders are ineligible to enroll as Medi-Cal providers. Consequently, residents with the PTL cannot bill for Medi-Cal services when moonlighting. So residents' inability to bill Medi-Cal for moonlighting services reduces the quantity of available providers. Another issue that I wanted to bring up has to do with leave policy. The strict requirement that medical school graduates successfully complete a minimum of 36 months of approved postgraduate training within 24 months of continuous training in a single program does not allow for extended leave for family and medical purposes. If resident takes time away from their residency, then they have to make up that time at the end to meet the requirements for licensure. This conflicts with specialty board, family, and medical leave policies and runs counter to the intent of leave policies, which supports resident health and well-being. The MBC staff have been really helpful in thinking this issue through with us. Therefore, we also look forward to continuing the conversation with the board to see how we can resolve these unintended consequences. Thank you.
Thank you for your comment.
Thank you.
Sean?
Next up, we have Genevieve. Genevieve, are you there? Clavriel?
Yes, I'm going to pass. Thank you for asking.
Okay, thank you very much. Next up, we have Rosie Arthur's daughter. Rosie, are you there?
Yes.
Please go ahead.
Let me see. Okay, let me see.
We can hear you just fine.
Oh, you can. Okay, great. Sorry about that. First thing I'd like to say is I've been online for this since before 10 a.m. and only a few minutes ago did I finally find out where the hidden icon was for raising your hand. I'd hit the share thing thinking that was it. That was plainly displayed. This was hidden somewhere off the screen and it's not ADA compliant. So that's something that's a real problem. Communication with the board has been a problem for a long time. 6 years ago, I attended a meeting after requesting information prior to that time in Sacramento. And one of those things was the task force that we're talking about now that was supposed to be starting up 6 years ago. So in 6 years' time, the task force has not come into fruition, and now we're supposed to wait another 18 months. So there's a problem. The issue of working by the statutes, absolutely. And as many of the boards and bureaucratic organizations within the state, they are working on what are called para-regulations. In other words, there's the statutes that's out there, and there's how people do business with whatever their agenda is in their organization, etc. So that with the changes in the pain control guidelines in 2014 that were gifted to you by workers' comp insurance companies, it eliminated the references to the laws related to intractable pain. They are still in place, and they are still a part of the enforcement protocols. But because it doesn't benefit the insurance companies, taking that language out then eliminates the patient's right to at least reference the fact that there is an alternative to being forced onto taking dangerous drugs or procedures for their intractable pain. So, and communication, whether it's written or you attend a meeting, nothing comes from it. It's dropped. So what Eric said is true, and there's just nothing. In over 6 years, there's been no response to anything I have written. So it's very difficult when we see one board referencing the same things, and that would be the osteopathic board, referencing the statutes.
Please conclude.
Okay. This is something that's an easy fix, okay? And pain patients need that. Ombudsman, great, need a lot more than one though. Things that were supposed to be put on the agenda, such as a presentation on intractable pain last November, never happened, nor at the next meeting. So things are ignored. The input is ignored, and the statutes of the state are ignored, and there are other consequences that come from that. So I'll put some comments in writing again, but please fix the ADA problem with the screen. The hand, raising the hand should come up.
Please conclude so we can get to other commenters.
Yes, thank you.
Thank you. Sean, next commenter.
Next up, we have Hannah Ree. Hannah, are you there?
Yes, I'm right here. Hello, can you hear me?
Yes, please go ahead.
Okay, wonderful. Thank you so much. So this is Hannah Ree, Dr. Ree, on behalf of Black Patients Matter. I'll keep my comments short because I would like some feedback from the medical board. So what we would like to see here at Black Patients Matter is, number one, all medical expert consultants to have significant work history in racial equality and religious tolerance. At the very least, all medical experts and consultants must work in a racially diversified patient clinic. Number two, we ask the medical board expunge the records of minority physicians who were revoked unfairly. As we all know from myself, with no prior complaints, no substance use, no mental illness, no charges of patient death, and revoked after filing a federal civil rights lawsuit for racism, which is still ongoing. And then number three, in the spirit of ultimate non-adversarial resolutions and budgetary concerns, there needs to be some type of mediation. I've always invited the medical board to the table to discuss and mediate a lawsuit, but it's always been denied, and so the lawsuit moves forward. So I would like to hear something back from medical board members. Thank you.
Thank you, Ms. Ree. Sean, can we go to the next commenter?
Yes, the last in queue that we have here is Anne. What I want to say, Anne, are you there? Thanks, Annie.
Just give her a minute. Can you see if she's coming on or off mute? Looks like she's
I
back
saw her
on
just
mute.
put herself back on mute. Anne, if you could go ahead and let me unmute you again. Don't worry about it. Yeah, it's not coming off mute. It's a mobile device, so you may have. Oh, there we go. Anne, are you there? See it going on and off mute, but I'm not hearing any audio.
All right, Sean, is that the last commenter in the queue?
Yes, that was the last I'd seen in queue here.
All right, I'd just like to invite the board members and executive staff if there's any final wrap-up comments you'd like to make. I personally have found this to be a good format. I'm already thinking ahead about how we can make it a different or longer format, or have another one perhaps in the afternoon or evening so a different group of people could attend, those sorts of things to make sure we're getting input and providing opportunities, because I recognize that for some people this is the middle of a work day, right? And they may not be able to attend in the same way if we had something like this at 6 p.m. Or 7 p.m. So I would just like to invite any wrap-up comments from board members or executive staff.
This is Howard. May I speak?
Please.
No, I think this has been a great session. We've heard a lot. We've learned a lot. It's been helpful to have a back and forth. The other observation is that much of what we hear is stuff we've heard before, which isn't bad. Sometimes they say the key to education is repetition, but it also strikes me that there are some things that we can do, some things that we can't do, and some things which are misunderstood. So when there's a request for greater transparency, there should also be an availability for us to explain what we can do, what we can't do, what our limitations are. And maybe there should be more information on our website to keep not only our callers informed, but the public informed. In particular, with regard to some guidance as to how complaints should be provided, how complaints should be channeled, the complaint process. The suggestion that one caller made for there to be information on our website to better guide the public in how their complaints should be provided, and with what documenting information and how they can help in terms of advancing their complaint. Those are all worthy comments. But for those things that have come forward and come forward repeatedly, it'd be good for us to have some kind of cogent response, so that number one, we take action where we can take action, and number two, we don't frustrate a caller who keeps asking for the same thing that we have no capacity to provide. So this has been better than any of the other public stakeholder meetings I've personally been able to attend in the past, and I'm glad that we're continuing this format, and it's a great start. Let's follow up on everything we heard today. Thank you. Thanks, Dr. Kraus. Any other quick comments from board members or executive staff?
Hawkins, is very valuable for me, and for those who are, I'm sorry, very valuable end of it. And it's time to start seeing some patients now. See everybody soon.
Thanks, Dr. Hawkins. Ms. Lubiano?
Oh, sorry. Go ahead.
Oh, yes. So I want to acknowledge that, this forum has been a work in progress. So I would ask for the public's patience, a little patience as we try to improve it and make it better. I think one thing that would help me for future reference is for this particular forum, if we could help outline what are our goals just overall with having this kind of forum, so that could help maybe focus our action and discussion. And also something that
I've talked to staff about for the future that I would like to see in the spirit of coalition building is to have more of an opportunity to learn about the stakeholders, the public advocates and other organizations out there, and allow them to speak a little bit about their mission, what they're all about, and some of their top priorities that they would like to focus on with us. And so perhaps in the future we can get to that. Thank you.
Thanks, Ms. Lubiano. Ms. Campoverde.
I just wanted to thank the advocates for vulnerably sharing their stories. I know revisiting that is hard, and I know that we're committed to continue these, so thank you.
Any other comments from board members or staff?
Christina, Bill Pacifica, can I have a quick comment?
Please.
Yeah, I think it's very important for us to go back, consider everything that has been said, but to think of very more constructive manners of engagement going forward. I think obviously there are certain themes that have been emerging and that are common across many different of the advocates. The obvious one is transparency, as Dr. Krause said. Perhaps what we could consider is at the next forum, why not have a forum devoted, if not entirely to advocacy, at least one which is sort of 80% devoted to that. It would be an opportunity for the executive to go and to maybe present on what are the current constraints in terms of transparency. And then in terms of a way forward, we can have, if you will, two tracks. One, what can we do now under the current legislation? And then secondly, if it's desirable to go further, what proposed legislation would perhaps rectify that, but then to consider as well what may be some of the unintended consequences of that. So what I'm suggesting is that I think we need to continually refine this forum, and as an idea, it may be better to limit the subject matter and to allow greater discussion of it and greater exchange. And I think if I can see there's one consensus which is developing from this, it's much better to have an interactive forum than what we've been doing in the past of just set pieces and then moving on. So that's my only comment.
Thanks, Bill. I appreciate those comments. And I would just, in conclusion, I'd like to thank everyone who joined the meeting today. I would really like to thank all of you who stayed on the line for 3 hours, right, and waited till the very end to provide your comments. And I regret that we weren't able to participate as fully as we were at the beginning of the meeting in light of the time limitations. I'd like to extend a special thank you on behalf of the board to Bridget Gramme from the Center for Public Interest Law for joining us, and frankly for pushing us with your good ideas as well. We really do appreciate that. For those of you who weren't able to fully provide your comments during this meeting, please do provide them in writing to the board. We will, to the extent we can receive those comments by May 11th, we'll provide them as part of our, we'll provide them to board members in advance of our next board meeting. And staff is also going to provide a report about today's meeting at our upcoming May 13th, May 14th board meeting. And I will now adjourn this meeting. Thank you all for attending.
Thank you all. Have a good day.